Axxess patient chart for our test patient, Temple test, Shirley Temple. So you both can see this?
Yes, ma'am.
Okay. So once you log in and you go into this patient's chart, this is what it looks like. It has the patient's name up here, our number that we assign them, whether it's a male or female, the code status, fall risk. This is based on previous information that was put in there, but basically when you do your Oasis, if you identify them as a fall risk, it will show up on their chart. Then it has their address, their date of birth, and their phone number. Usually there'll be a picture here. We haven't added a picture for this test patient, but if you click on their address, it brings up Google directions. So that's always a nice feature. So if you need help finding the patient, does that show up on their screen? I don't see it.
Wow, multiple people? Okay.
All right. So again, the episode timing will be listed here. The start of care date will be here. The doctor, the insurance, who's the primary contact for the person, and if there's a secondary contact. Also, let me move you over here a second. You have the patient profile here. If you click on that, it brings up everything that's on that little square, patient's address, date of birth. But this is something you can print out and take with you, and then you can write notes on it if you want to. That's what I do. I print these out and I take them with me, and as I do them, I write all over them. Because I never have time to do the computer in the house. I usually do it when I get home. Okay. Then there's a refresh button here. Remember, you're working and you want to refresh the information, you can hit that button. Then there's the quick links, which is helpful if you can't remember what the patient's allergy is. You click there and the allergy that was put in will be here. Same thing goes for the med profile. If there were meds in here, you'd see it there. Immunization profile. Okay. And then there's the vital sign chart. If you document your vital signs in your notes and you ever need, say, like a blood sugar for the last 2 weeks, you can just go in here and print it out. If you don't put the blood sugar in the specific spot in the note, though, it won't show up in there. So I'll point that out when we get to it. You never have to worry about if you delete something by mistake, meaning a visit, because the deleted tasks will show up in here. We can always restore them. So don't worry if you hit delete by accident. Okay? Let me move you back over here. Okay. So we're assigned to Shirley Temple today to do a start of care. So the tasks are here. The date that the scheduled task is here. The person assigned to do the task is here, and the status is here. Comments can show up here. Jasmine might put in a little note for you. Like if we know that the B12 shot is due today, she put that in there for you. Down here, this one says, next visit is and the frequency, please call the office and let us know if you're planning on continuing nursing or discharging. Okay, so whenever there's a little yellow sticky in here, you can hover over it and click on it and it brings up the note. Then, I'm going to move you again. Then the next screen, you see these little houses. When you use your mobile app to log in and out of a patient, once you close the note, it turns green. The exception to that is if you don't use your mobile app and you use, let's see if they can see it, these paper logins, when you hand those in, then we would attach them to this area here. Okay? These attachments say that there's something in here. So Jasmine put this together for me this morning. She went ahead and she put in here the initial order. So you can click on that and open it up and it'll say, oh, here's your initial order. And,
Minimize it.
okay, the referral is also here. Click on that, you can open it up and read the referral. I went ahead and put the assessment sheet in here that I made up for this patient so you can see that. The assessment sheet that you might have seen in your folders before looks like, let's see if you can see it, this, a little bit different. Can you see that?
That's a little bit, it's blurry.
It's
Yeah,
blurry.
back it up a little
When you
bit.
back it up, it looks like this.
Mhm.
Okay, we're changing that to this one that's in here, because the one that's in here, that I filled out, this one is called an Oasis E Start of Care cheat sheet, and it has every question on it that you'll find in the Oasis, so it's much better. So eventually we'll get those in, we're waiting on printing, I think.
Printing, and also I will email each of the nurses that, so the RNs, so you guys can type it in, fill it in, and whatnot.
Oh, that's nice, okay. Okay, so, let's see what I did. Can I minimize that? Here, I just move them around, yeah, let me just move there. Okay, so the Oasis E, you don't have to put the initials like this. If you want to put the last name and the first initial, that's fine. I just put TS. The start of care date, the date of birth. I don't really care about these two questions, but if you want to fill them in. Hearing, vision, and preferred language, and then you go through your vital signs. Assistive devices, whether or not they're incontinent. So as we go through, we'll fill this in. And then there's a back page. This area will change. This reason for referral, your order tells you why you're going in. This is going to turn into a question of, does the patient require home health aid assistance, and did you tell them about First Light, our sister company? So that'll be there. Patient's diagnosis, some more questions, and then you get down to the doctor, the last time they were seen by the doctor, whether there's any allergies. So as we go through the Oasis, we'll use this page. Okay. So that shows all the attachments, and I also had her just throw in here the wound picture, and when we get to that part of the Oasis, you'll see how we take that and move it into the Oasis. Hold on one second. Try not to laugh. The picture is hand-drawn. And it's not a gross wound, it's just a wound. So, there you go. All right. Okay. So, we come back out of here, back to the patient's chart. Here's your start of care. So to get into it, you just click into it. Your pages are here on the left. Starts out with a demographic page, the history and diagnosis, risk assessment, prognosis, and so on and so on. And you'll move on from this page when you get to the bottom. You can tell it's the bottom because you come to this pink color, and then you'll just hit save and continue. It saves the page and it takes you right down to the next page. And then you fill that out, and so on and so on. If you get interrupted and you have to stop, all you have to do is hit save and exit. And you can always come back to it and continue on. Don't forget to hit save. If your area is prone to power outages, every time you do something, especially if you're writing a narrative and it's quite lengthy, you might want to hit the save key so that you don't lose it in case there's a power outage or something. So you can just hit save and then move on. Okay, so we'll start here. All right. You both following me so far?
Yes, we are.
Okay, if you want to interrupt, just say, hey, I got a question, okay?
Okay.
What do I do with them here? Let me do them over here. Okay. So, Axxess gives you the ability to use a previous assessment. And you would click on here and it'd be a drop down and it would list the assessments that are in there. If you wanted to, say you were in doing a recert and you were the one that did the start of care, so you want to copy most of the information from the start of care, you would be able to click on that and then hit load assessment. But then you still need to go through every question and make sure things haven't changed, okay? For right now, we don't have a previous assessment, so we're gonna just go through it and do it all. Okay, so today's a visit date. We'll say that we went in there at 8 o'clock. The visits need to be at least an hour for start of care. Sometimes you'll be in there 2 hours, just depends on the patient. So your visit time, or visit date, visit time in, and visit time out. That's all you have to do. There's none of this travel time. We don't use that. If you set up a surcharge with one of the schedulers, you'll see that here. So if they're giving you $10 extra for going or $25 extra, you'll see that here. So all of this information is grayed out. This is what we use when we put the patient in the computer. So you won't be able to change any of this. So if you see anything in here that's wrong, you just call us and say, hey, this is not a man, this is a woman. So patient's name, date of birth, all of this information is on the front page that we were looking at before. This patient is self-pay only because we couldn't put it in as a Medicare patient and have it a test patient, so we just put self-pay. But most of our patients will be Medicare, traditional fee-for-service, or a VA patient, and we are taking some HMOs now, so you might see that. All right. So you go through and answer any questions that are not filled in. This one wasn't filled in, so we know from our sheet that the patient's preferred language is English. So you just go ahead and click in there. It gives you a drop down. You can choose it, and it'll be in there. Do you need or want an interpreter? Yes or no. Unable to determine is no. This is where your move questions start. These are the Oasis questions that determine the patient's need for services, and this is what Medicare looks at. MU 80, the discipline of the person completing the assessment, it's RN. This is the start of care and the date that the assessment was completed. We're going to put today's date. Dates and times. Date of physician ordered start of care. If the doctor specifically wrote for a date of the start of care to begin, you would put that date. Otherwise, it's no specific date was entered. And we put it yesterday. Yesterday was the date of the referral. You don't need to worry about this. We'll handle this. Okay, and we're at the bottom. It doesn't go any further. You just hit save and continue. Takes us to the next page. The next page, you use your assessment sheet. You have that with you, and then you just go through and populate the information. Okay? And then it'll ask you for temperature, the route they took it, temporal or oral or rectal. I put 16. You can get oxygen saturations on all your patients. It used to be that we needed an order, but you don't anymore, so you can. Most of the nurses are getting oxygen sats when they do the start. Pulse. 72. Let's see, it's April. You can toggle between left and right by using this key up here. All right, this is a special hidden measurement. If you click on the additional measurements, this is where they hide fasting blood glucose, random blood sugar, abdominal girth, hemoglobin A1C if you have it, INRs, PTs, If you're measuring ankle circumference or calf circumference, you can put it in here. I went ahead and put abdominal girth on here, so I'm gonna add this in here. 42 inches. And also, we said this patient was a diabetic, so I think I made up a couple things. 6.5. Whoops. 6.5. And if you're gonna put that in there, hopefully you have a date that that was done. And the glucose, we said was 142. We'll say that was fasting. Okay, so then you have that information in there, you hit save and close, and it's in there. Okay, and you can always click back into it if you needed to. Then you come to parameters. Parameters are pre-populated for you. However, if your patient is not a diabetic, you would take this out. Just erase it, okay? We got nailed on a survey because we had parameters for blood sugars on a patient that was not a diabetic. So everything in here you're going to tailor towards your patient, but some things are pre-populated. You can change them though. Some patients have a normal heart rate of 56, so you don't want to have 60 there as the low. Otherwise, you'll be calling the doctor every time you go in there. So you just adjust that based on your patient, okay? This is grayed out. This is where the patient came from. If you see that it says short stay in the hospital, but you know the patient didn't come from the hospital, he came from a doctor's appointment, just call the office and we'll fix it, okay? This is a discharge date. When did this patient get out of the hospital? I'm going to put the patient got out yesterday. We have 48 hours from discharge to get in there and get services started. Nursing is very good about this rule with Medicare. Physical therapy is terrible. When a patient comes out on Thursday and we have the nurse do the start of care on Friday, we would like therapy to get in there on Friday, but they can't, and they never want to work on the weekend, so usually I end up writing an order so they can see the patient Monday or Tuesday of the following week. But they really have 5 days. Once we're in there, they have 5 days to get in there. So we'll handle them. You don't have to worry about that. Then there'll be some diagnosis put in here from when we admitted the patient in the computer. If you don't think they're correct, you're like, oh, that patient's not a diabetic, call me and we'll take this out of there. Or if you are with the patient and you see something that's not listed here, like say COPD, you can try and add it like this. You try and do that, and then pick which one you want. Okay. And don't forget your severity codes. This is how likely is the patient to end up back in the hospital. 4 is very likely. 3 is there's definite need for monitoring with nursing and teaching. 2, there's need for teaching. 1 is the patient is stable and there's really nothing that we need to do with that. And I might have this turnaround. I have to check on that. Let me just see something here. Severity codes. Severity codes for Oasis. Okay. So 0 is asymptomatic, 0-1 is symptoms well controlled, 0-2 is symptoms controlled with difficulty affecting daily functioning, patient needs ongoing monitoring, 0-3 is symptoms poorly controlled, patient needs frequent adjustment and treatment and dose monitoring, and 0-4 is symptoms poorly controlled and there's a history of rehospitalization. Okay? Is that one of you?
Miss Laura. That's me.
Yes.
Miss Laura.
Yes.
Is this the same as Kinsler? Because I usually put 2 because it makes more basic when you go in there. 2 is mostly appropriate.
I'm sorry.
You are people to be. I said, is it the same thing as in cancer? Because cancer 2 is more or less the most appropriate one when you are requesting for more basics on this page, on the patient.
Yes, 2 or 3, yes. This is very similar to Kinzer, yes. You would never want all of these diagnoses to be a 0 or a 1, because why are we in there? So 2 or 3 is appropriate, yes. And even 4, if you run into a patient that you're like, why did the hospital send this patient home? He's gonna end up right back in the hospital. You can put 4, okay? Did that answer the question?
Yes, ma'am.
Okay.
You can walk continue.
Okay. So, yes, you can add diagnosis here, okay? And then if you want to move them around, patient has diabetes, but you think that the hypertension is the reason why we're in there, you just give me a call and we'll move it. But you can shuffle these in here. You don't need to. QA is going to play with them anyway, so make sure there's a severity code for everything though. Otherwise, when you go to log out, you won't be able to because it'll tell you that there's a missing severity code. Okay. Core morbidities and coexisting conditions, move 1028. Does the patient have PVD, PAD, diabetes? Yes, we're going to say, or none of the above. And any special treatments or procedures? We're going to say no. Okay, there's all kinds of allergies listed in here already, so we'll just leave that alone. You get to the bottom, go save and continue. Shingles vaccine. Has the patient ever reported getting the shingles vaccine? Well, it's already listed here, so we'll say yes. If the patient said no, then it will ask you, did you administer the shingles vaccine? We don't offer the shingles vaccine, so we'll put no or patient declined. And the reason, he doesn't believe in vaccinations or whatever. So we're going to say no. But this one, he has it listed on his immunization, so we know she got it. Okay. Then potential risk for infection. Does the patient have a wound? We're going to say yes. Does the patient have a history of recent respiratory disease? This patient has COPD, so we're going to say yes. Is there a catheter? Yes or no, whatever. And then you go down to confounding factors. The patient does have a history of COPD, poor mobility, is on antibiotics because we're going to say that she has a UTI. So now you have this identifying risk factor thing. It says if the patient has one or more confounding factors and one or more. Hold on 1 second for me. Take a break. Hello? Yeah. sorry. All right. Huh? Oh, it's in my pocket. Okay. All right. I am back. Sorry about that. Okay, so this is the potential for risk assessment. So this is where we're going to identify factors that are increasing the risk for infection. And then down here at the bottom it says, identify the patient's risk for infection based upon agency policies and procedures. If the patient has one or more confounding factors and one or more predictors, consider choosing a problem statement below to address the potential for infection. Selecting high risk for infection will identify the patient as a risk for infection on clinical notes and infection control reports. This patient, we're going to say, has a UTI plus all these other factors, so this patient is a high risk for infection. Where that goes now is into the plan of care. Down here at the bottom, orders for discipline and treatment, high risk potential for infection. This statement is, patient has been assessed to be a high risk for infection as evidenced by, and I'm going to put in here, current UTI, diabetes, and history of COPD. Okay. SN to instruct on infection control, precautions such as hand hygiene, personal protective equipment, waste disposal, environmental sanitation, and signs and symptoms of infection to report. You could technically get rid of most of this and make your own statement. SN to instruct on infection control precautions, and I would put related to UTI, diabetes, and COPD. Then, when you come to interventions, you can pull out, like for urinary tract infection, that would be genitourinary. So you click there, the intervention is SN to assess for signs and symptoms of, and I don't like all this, I'll just put UTI. And instruct patients, and if there's no caregiver, you want to get rid of the caregiver. So you're taking out the asterisks and making this fit for your patient. So SN to assess for signs and symptoms of UTI, such as, I like to put them in there so that they know what you're going to be telling the patient, such as burning with urination, frequency, whoops. Let's see. Fever, increased confusion, and give me something else. Are they there? They're there. Okay. Can you still hear me? Okay. All right. UTI, burning with urination, such as, let me do that, such as burning with urination, frequency, fever, increased confusion, and, I don't know, give me one more symptom of a UTI.
Anything?
Discolored urine, I guess. Then, then you will go on, your next one will be the diabetes. That puts them at high risk in COPD. So you're gonna remember on your next one, you're gonna go to respiratory, and you can also add additional high-risk infection orders, okay? So you wanna make this fit your patient. You don't wanna have these generalized statements, so you wanna change things. Solid urine, instruct patient. Patient regarding care system, including, you don't have a catheter, but maybe you want to instruct on proper hygiene, wiping front to back and stuff like that, washing their hands. All right, so once you get that to sound the way you want it and it fits your patient, then you can move on. So that's an intervention. The next thing they'll want is a goal. Patient will remain free of UTI during this episode of care, or patient has a UTI right now, so maybe you'll go to patient will be able to verbalize signs of UTI. Okay, so I'm going to get rid of this. Don't worry, we won't do a whole bunch of these, so. Patient will be able to verbalize signs of urinary tract infection. Period. Such as, and then you'll go ahead and list what you put up in the top there. Let me just get rid of that. So I go up here and then I'll copy burning with urination fever. Okay, copy. Throw it in here. So then you want to assign a time limit to that. Patient will be able to verbalize such as burning and to report and who to report these signs to. So when you're doing your teaching and you're going over signs of urinary tract infection, you want to tell the patient, okay, if you start having burning when you urinate, you want to let me know, but you want to let your doctor know too. So that would be part of the teaching, that they know who to report those signs to, and then you'll go ahead and assign a time limit of, like, you want to have short-term and long-term goals. So pain is definitely a short-term goal. We'll put infection, signs of infection as a short-term goal. So we'll say within 2 weeks. So now you've got your intervention, you have your goal, and it's measurable. And then you can go on from there and assign, maybe you'll go into respiratory precautions, teach respiratory precautions. They have COPD, so you're going to teach pulmonary toileting, deep breathing and coughing exercises, plenty of water, whatever, okay? That's how you'll build that risk for infection in your care plan. So then you're done with that, you'll hit save and continue. If you forgot to choose a goal, it won't let you continue. This would be highlighted in red and say you need to pick a goal. Okay? But when you get to the bottom of the page, save and continue. If you've done everything you need to do, you can go on. Then it will ask you advanced care plan based on your assessment of the patient. Do they have a living will? Do they have a surrogate decision maker? I don't care if they have legally assigned somebody as healthcare surrogate. I ask them, who would speak for you if you couldn't speak for yourself? And it's usually one of their kids or their spouse. So if they say they have a surrogate decision maker, I go ahead and put the name of that person at the bottom here. And then I put their phone number. So you can always write in these comment boxes. All right. And then you hit save and exit that screen, and it'll take you back to your Oasis. Okay? You come down to prognosis. I always put fair on every patient. I never put good or excellent. If there's a need for advanced care planning, you talk to the patient and they're like, oh yeah, I'd like to have a living will. You can add the need for advanced care planning to the care plan by getting a social worker out there. So we can mark social worker indicated for long-term care plan. The goal is patient will be able to verbalize benefits paid to PCP by Medicare. Who cares? I don't even know why they put that in there. Patient will be able to verbalize need for advanced care plan. Well, he did, so I guess that's good. Get rid of the caregiver. Patients will be able to verbalize the, and we'll say that was within 2 weeks also. All right. So that'll go in the plan of care. That'll be something that we're working on. If you think of anything additional, you can add it here. We're at the bottom, save and continue. The cultural preferences is important. This is a new question on the Oasis E1. If there are none, you just hit none and it closes it out, but you can't leave it blank. You have to answer something. Patient's living situation. If the patient lives in an ALF or residential home, you mark this. If the patient lives at home with their spouse, you mark this. If the patient lives at home alone, you mark this. Doesn't matter about regular daytime, nighttime. There might be an aide in there, but I don't care. We want Medicare to know that the patient needs us to come in. So I just put whether they're alone, whether they live with someone, or whether they live in assisted living. Transportation. Has a lack of transportation kept you from medical appointments? Blah, blah, blah. Yes, sometimes they live alone and they don't have transportation. Maybe we get them set them up with Palm Tram, okay? Or they'll say, no, my daughter takes me everywhere. Health literacy. This is a question on that assessment sheet that you filled out. It says, how often do you need to have help from someone to read pamphlets or instructions from your doctor or pharmacy? Sometimes it's often. Sometimes it's rarely or never. It just depends on how they answer. Or they'll say no, and you know that they don't know how to read, so it would always be always. Psychosocial.
Susan Cantalupo.
Sorry. Psychosocial. I always put something here. So you can write no problems, but I doubt that's the case. If the home environment is altered in any way, if they're living without water, or they're living in clutter, there's nobody there can indicate that, because all of that justifies why then we bring the social worker in. If there's nothing there, I always go to barriers to health, and you can put that they have multiple comorbidities. Maybe they're unmotivated in learning how to take care of their nebulizer machine. Maybe they don't have any food in the house. So I document something. And even if it's just that they have dementia, and you can't really teach them, I'll just put dementia. Or Alzheimer's, or whatever is indicated. And then community sources needed, yes, we need Meals on Wheels, or we need adult protective services to go in there. But that's something that you and I will talk about when you give a report. So I'll take care call in those agencies for you. And then this question needs to be answered. Is there a caregiver? Okay, so we can say caregiver, 4 hours, 3 days a week, and then put assist with bathing. So that we know there's somebody in there 3 days a week helping with bathing. If there's nobody in there helping with their ADLs, it's no caregiver. If it's a VA patient and they have the VA Aid and Assist program, because veterans are entitled to this Aid and Assist program, you might want to say VA Aid 21 hours a week. Okay? So we'll say no. Safety measures. This is a plan of care issue. Safety measures. Do they require 24-hour supervision? She lives alone, so hopefully not. Aspiration precautions? No. Bleeding precautions, if they're on Eliquis, Coumadin? Yes. Aspirin? Yes. Diabetic? Yes. If they have oxygen? Yes. Emergency disaster plan development, do they know what they'll do in an emergency? And not just a hurricane. So I always ask, if there was a hurricane, are you staying at home? Yes. Okay. How are you going to run your oxygen if the power goes out? Oh, I don't know. Well, we're going to get you set up with emergency shelter. Or, I have a generator. Fine. Okay. And I document that. Or my son will come and get me and I'll go to his house. We just need to know that they know that, what they're doing in case of a hurricane. If there was a fire in your apartment complex and you had to go somewhere, where would you go? Oh, I don't know. We need to register them for emergency disaster. If there's a fire in the apartment and they have to go somewhere and the son lives down the street and she would go with the son, fine, then we document that. Fall precautions, keeping pathways clear. If there's animals in the house, you need to indicate it. Okay, if they're prone to skin breakdown, safety, proper handling of biohazard, they have a weeping wound and there's just dressings all over the place, that's a problem. If it's a diabetic, usually there's sharp safety, infection control for everyone, support during ambulation and transfer, and assistive devices. Okay, so this care plan problem is alteration in home environment. You can click on it and see, is there a need for a social worker to go in? It's a hoarder. There's like a 5-inch space for you to crawl in to see the patient, or something else. You can indicate that there. Save and continue. Sensory. All of these areas have dropped down. It's like abnormal pupils and vision is where you'll find glasses, whereas corrective lenses, that's at the bottom there. Or if they're blind, you can indicate that there. Hearing impaired, it'll ask you, are they hearing impaired in both ears? Yes. Do they have hearing aids? Yes. It might be that you put in here, patient states she lost her hearing aids. And then you start with some more questions, the questions that determine their need for us to be in there. The patient's ability to hear. This is one question that I'll accept a 0 if it's truly that they don't have any problems. But most people, as they get older, have some difficulties. So even if they're not wearing hearing aids, I put a 1. And then if they're wearing hearing aids, when they take those hearing aids out, what is their normal hearing? And it might be moderate or highly impaired. Ability to see adequately with glasses. Okay, they have glasses, so I'm going to put impaired, sees large print, but not regular print or newspaper books without their glasses. Those two questions are easy, but when QA calls me up, they get mad because everybody tries to put zeros on everything. This is how we build a case for why we're needed to be in there. So there can't be everything that is perfectly independent and normal for the patient. We have to show some deficit. We're not lying, but whenever you answer questions, the MOOC questions, you end them by saying safely. We'll get to that shortly, it's coming up. This pain assessment is a big thing. If the patient has tramadol on their med list, you cannot say they don't have pain. You must say yes. And then you say to them, okay, you have tramadol, where is your pain? Well, I don't have any pain. Okay, but when you do have pain, where is your pain? Oh, my lower back, okay? Lower back. And then from there, you're gonna have them current pain intensity. Okay, they can say no right now. And maybe they'll put no here. But when you do have pain, what was the pain score? And they'll say, oh, I was up all night. Okay, so it was distressing. And does it interfere with activity? Yes, I couldn't sleep. Or I couldn't walk to the bathroom or whatever. And then, does that happen less often than daily? Daily, but not constantly, or constantly? Okay, so for this patient, we put less often than daily. And have them describe the pain. Is it an aching pain? Is it a sharp pain? Is it tender, the area tender to touch? Is it throbbing? And are there any nonverbal cues? When they go to stand up or sit down, are they grimacing? Do they yell out? Are they always sitting because it hurts to stand up? Pain relief measures, what do you do when you have pain? Oh, nothing. Okay, well, do you ever take Tylenol? Oh yeah, sometimes I take Tylenol. So you have to dig in, because they like to say nothing's wrong, but then you find out there are answers to these questions. Sometimes I just rest, put my feet up and rest, or I'll use the heating pad. Current pain management effectiveness. Now, using these things to help your pain, do you get any relief? Well, I can't move any more than I usually do, but it makes me feel better. So it improves their mood, but it doesn't really help their physical functioning. And then, of course, you have the question, is the patient showing signs of aberrant behavior towards pain medicine? Oh, I need some OxyContin, my back hurts. Well, you got 3 bottles there, you know. So you know the drill for this question. So ask the patient over the past 5 days how much time has pain made it hard for them to sleep at night. Okay, so you say occasionally, or whatever they say. And then ask the patient over the past 5 days, how often has pain limited your participation in therapy? Well, they haven't had therapy in the last 5 days, so the answer is does not apply. Ask the patient over the past 5 days, how often has pain limited your day-to-day activities excluding rehab and physical therapy? Oh yeah, sometimes, so but occasionally. Because of these answers and the patient has pain and pain medicine, you want pain on the plan of care. So alteration in comfort, pain, SN to provide skilled assessment, teaching, training, and reinforcement of teaching to properly assess, manage, and mitigate pain. And then you could individualize this by saying patient has lower back pain, okay? And then we're going to teach pain. So SN to instruct patient. If there's a caregiver, you can teach the caregiver. Regarding strategies to mitigate pain, including things, medication administration, recording or reporting pain, non-pharmacological treatments, including positioning, massage, visualization, distraction, and warm or cool compress. You can break that down and individualize this statement any way you want, but for time, we'll just leave it like that. And then that's your intervention, and now we go to goals. patient will be able to verbalize pain relief measures. Oh, well, when I'm having back pain, I take 2 Tylenol, or I lay down and put my feet up or something. Okay, so patient will be able to demonstrate pain relief measures to mitigate pain, and like I said, pain is definitely a short-term goal, so we'll put within, you can put 1 week or 2 visits or whatever. And now comes the questions that add to medical necessity and homebound narrative, and pain is a good one for both. As you go on the Oasis and go into each system, you'll have the opportunity, if you need to, put a problem in your plan of care regarding that system. These problems can generate medical necessity and homebound narrative, but you do not have to do that on every single problem. You just need to have one of each at least. So for pain, we're going to use this one. Pain interferes with activities of daily living. I'm going to hit that. And I'm going to put patient with moderate pain, because if it's excruciating, I better be calling the doctor. Patient with moderate pain, interfering with functional status, thereby impacting activities of daily living. And there, if you want, you can say, patient states she can't stand more than 10 minutes, unable to shower herself, something like that. That justifies why we're going in there. And then you have the homebound narrative. It is not required to enter a homebound narrative for every problem statement, so just remember that. I always use the pain because that's the easy one. Patient with pain that interferes with activity causing decreased mobility, avoidance of activity, and taxing effort to leave home. And then if you want, you can say, patient reports low back pain interferes with ability, hope I'm spelling else right, ability to stand more than 10 minutes without needing to sit down. Okay, that's one homebound narrative. I mean, the patient can't stand more than 10 minutes. They can't go out to the doctor's office because it's too much for them to get on transport and walk to the doctor's office. So that justifies a homebound reason for this patient. Another one might be, you can add one, patient is so short of breath that they can't leave the house without oxygen and they don't have anyone to help them. That's another one. All right, so you have one here. We're at the bottom. We hit save and continue. Okay, integumentary. This is the problem child of everyone for Axxess. If you have a wound and you do the start of care today and you are expecting an LPN to go in and follow your case, you have got to get your wound in today. You might not have time to do the rest of this Oasis, but you must get your wound in. So even if you didn't do anything else, you're going to come into integumentary and hit wound. And then you're going to identify the type of wound, and I think we put it in as a pressure ulcer here. So pressure ulcer, that's fine, and you can go down, skip all this other stuff, because all we're doing now is putting the wound in. You're going to go into wound manager. In order to add a wound, you're going to have to say wound orders profile, add a new wound order. We're going to say this is a pressure ulcer, or you can freehand the whole thing. So I'm just going to go with pressure ulcer. SN to perform pressure ulcer care to, we're going to say stage 2 to sacrum. And then SN, oh, sorry, we want to put a frequency, stage 2 to sacrum, and what I like to do is I put my measurements in there, 2, CMI, 1, CMI, 0.1. So I like that, whoops. All right. So I have my measurements in there, and I also want to put my frequency. SN to perform pressure ulcer care to stage 2 to sacrum, the measurements, and I'm going to say 2 times a week. Period. And then I'm going to put SN to cleanse. Cleanse wound with normal saline and pat dry, covered with foam dressing. Get rid of this. And you can keep the statement or not, I don't like it, because there's no caregiver in there. Okay, so SN to perform pressure ulcer care to stage 2 to sacrum, the measurements, how many times? SN to cleanse wound with normal saline and pat dry. Maybe you'll put, apply skin, prep, hairy, and cover the foam dressing. Okay, so there's your order. I put a very vague foam dressing. Unless the doctor wants Methlex, we'll just say foam because we use a different kind of foam dressing. It's called comfort foam, and it's cheaper than Methlex. The doctor wants Methlex, fine, we'll use Methlex, but if we can, we'll go with the cheaper version. So once you write your order, you're going to hit save and create. If the patient had more than one order, you can go ahead and duplicate it by hitting duplicate, and then say it's in a different area and different measurement, you can adjust that there. We'll get rid of that for right now. Okay, so once your wound is done, you hit save and create. Now you're able to add your wound to the man picture. So we'll hit back, we'll hit sacrum, add wound location, sacrum. We'll say it's on that picture was on the right. Oops, sorry, wrong one. So if I mess up, I can delete that, go back to add wound. Okay. I've taken a picture of the wound and I uploaded it to my computer so I can go and get it and put it in here. You'll have to figure out how to save your wounds, or you'll have to send them to me and I'll put them in for you. Oh. Tricked me. There we go. There. I think we lost connection.
I don't want to respond.
Lovely. Anyway, we won't. Yeah, wait for program to respond. Are you guys still there?
Yes, ma'am.
Okay. All right, because we just lost.
Yeah, we can see you.
Okay, here it goes. Okay. So, I don't know what's up with that. That picture is small. Okay. think the way it was downloaded in here, it's a little small, but let me see if we can get it. Yeah, it's not showing up. Anyway, that's how I save them in there, and normally it works, but I don't know why it's not. Then we go in and we've already said it's the left sacral area. We can get more descriptive of the location if you want, if there's something else. Sometimes on the picture, it's hard to get exactly where the wound is. So the onset date is the date that you're documenting this wound. And the wound might have been there for 2 days, but you found it today during your start of care, so it's today. Present on admission, yes. So we're doing the start of care. Type of wound, pressure ulcer. We're going to say it's a stage 2. And then you are going to select your wound order that you already wrote. You click on that. There's the order you wrote. You're going to hit associate, and then it brings it over here. There's the associated order, and then this is the treatment performed. So you have to make this make sense. You don't work the way this is written, SN to perform pressure ulcer. You're going to say SN performed pressure ulcer care. Okay, stage 2 to sacrum, and then you can leave the measurements if you want to, but you're going to get rid of 2 times a week because that's part of the order. That's not what you did. Okay, so get rid of that. And then we'll say SN cleansed, so we'll get rid of 2. Cleansed wound with normal saline and padded dry. Applied skin prep to peri-wound and covered with foam dressing using aseptic technique. That's what you did. Now you hit create wound. Okay, and it puts it here. Your picture will be there if you got it in there. The order's here. What you did is here. And now you're going to document on the wound. We said we measured the wound, so yes, we're going to put, I think it was 2.2. And 1.5 and 0.1. Okay. Type of tissue, epithelial, skin surrounding wound, normal or abnormal. I'm going to hit normal, wound edge, normal. Wound drainage, yes, we'll say there was a little bit. No odor, there was pain, it's discomforting. Signs and symptoms of infection, no. Patient tolerated procedure well. Caregiver able to perform procedure, no caregiver available. Patient is non-adherent to maybe offloading. Okay. Once that's all done, you can hit complete. If you're not done, you just got the wound in there, but you haven't finished documenting on it, you can hit save and exit, and you can always go back to it. Now here's your wound. You can go back to it, finish documenting on it, and once you're done, you'll hit complete. It turns green when you're done. Then you have the care plan. And of course you want to put this on your care plan. So what I do is I go into wound orders profile, I grab the order that I just wrote, I copy it, then I put it in my care plan. Alteration of skin integumentary status. You have this can statement here, but I go down to additional integumentary orders and I'll add it here. Paste. So it became part of my care plan. So once you or the LPN are doing a regular visit note, and you go into the care plan, you'll see that in there and you can just mark that you did it. Okay? And you can take out your measurements here if you don't want them in your care plan, because you might be measuring again, so you don't want to have those. And then that's an intervention, and you want to add a goal for that. And you can do something simple like we'll have promotion of healing and restoration of skin integrity without complications. You can say within 4 weeks or 6 weeks or whatever you want to put. Okay, so now you have a couple of short-term goals, and this is your first long-term goal. So you know that you can have at least one of each right now. And then your phone rings and you gotta go pick up your kids, so you hit save and exit. Okay, so you started your start of care, and then later you go back to it, you just click into it, and you can pick up where you left off. Okay, so we know we did pain, we finished that, and we were on Integumentary, so now you can go back and answer more questions here. Does the patient have poor skin turgor? Yes. Is there some bruising? Yes. And then physical condition will say fair, mental condition will say alert, activity, walks with help, mobility, slightly impaired or very impaired, incontinence, we'll say usually urinary. That gives you a score on the Norton pressure, SOAR pressure, risk assessment. It gives you a 15, which means the patient's at medium risk for pressure ulcers. Does this patient have at least one unhealed pressure or ulcer or injury stage 2 or higher? Yes. And then you'll have to go through and answer all these questions. Partial thickness, loss of dermis, presenting as a shallow open ulcer with pink or red wound bed, but that's where we are. We'll say yes. And then the rest of these are 0, 0. Now you may have another wound on the heel that's unstageable. You can put that here. But you want to make sure that if you have any wound care orders for that, that you have put it on the wound manager. Because if you don't, you or the aide will not be able to document on them on the next visit because they won't be there. Intact skin but non-blanchable, say no. Most problematic unhealed pressure ulcer is 2. Is there a stasis ulcer? No. Does the patient have a surgical wound? No. Now here's your wound manager, and you're already done because you did what you were supposed to do, and you already put your wound in there. But now you can come back and address the care plan. This CAN statement, SN to assess integumentary status, identify any signs or symptoms of impaired skin, report changes, significant changes to the physician, SN to instruct patient on disease process, including who to contact if signs and symptoms persist, blah, blah. You can leave that CAN statement, or you can take parts of it, or you can do whatever. We're gonna leave it for time right now. So that's one problem statement. And then you can also teach pressure ulcer prevention, since you have a pressure ulcer that you're dealing with. And you put the wound in there, so that's there. Your goals are to have healing and restoration within 6 weeks. Here again, you can either skip this. It is not required to enter medical necessity for every problem, but you can if you want to. And we can put patient with a new wound, stage 2, sacrum. Requires skilled intervention to manage and monitor for complications, teaching and training for patient, but there's no caregiver, and the patient's not going to be able to take care of this wound themselves. So patient, teaching and training for patient to report any further issues with skin integrity, but especially on her feet. All right, and then if you want to add in here, for skin, but you can also add it later in, endocrine, diabetic foot teaching, we'll add it later. Okay, here you can add more of a homebound if you need to. We're gonna go on. Get to respiratory. If the patient is on oxygen intermittently, you fill out here. If they're on oxygen continuously, you fill out here. If you have a tracheostomy, here, nebulizer here, CPAP, BiPAP here, abnormal breath sounds here, they have a drop down, okay? Shortness of breath, and you can put here patient reports, patient short of breath with moderate exertion. Then you go through your respiratory question. Patient is not short of breath, no. Patient is short of breath when walking more than 20 feet or climbing stairs. Yeah, most people are. And with moderate exertion, yes, we're gonna put that. Try not to put patients not short of breath if there's COPD or asthma in the history. Most people are short of breath climbing stairs, so you're okay marking that one. Alteration in respiratory status. If you want, you can go ahead and add this to your plan of care. The patient has a history of COPD. We're seeing the patient for diabetes and a wound. So there is a history of COPD. You do not have to add it to your plan of care. You're not dealing with that right now. But you certainly can. If this patient needs teaching for COPD, you can add it. Otherwise, you can go on. Cardiac status, if they're shiny legs, they have signs of cellulitis, you mark that there. If they have edema, non-pitting, and then pitting over here. So there's a drop down for each one. Fatigue and weakness, we'll just put that. And activity intolerance, we'll put that. You can add a problem to your care plan if you want to, but if you're not really doing anything with the cardiac, you don't have to. You can just go on. Elimination, we're saying this patient has a UTI, so we're going to put UTI signs and symptoms. We'll put new marked frequency, or we're saying this patient came to us on an antibiotic, so we know she has a UTI, so started antibiotic therapy. We can add a new med to the plan of care, but we haven't even got to med yet because we're at the start of care, so we won't bother with that right now. All right, if there's a catheter, suprapubic, the last time it was changed, and who manages it? Some we manage, and some Dr. Burnsley goes out and sees. I don't know if Dr. Burnsley goes to Broward County though, so I don't know if you would ever have him. But there might be a urologist that goes to Oakmont that does it, I don't know. And then a regular indwelling Foley catheter, same thing, date of last change and who manages it, okay? We'll just say no for right now, okay. Last bowel movement. She had one yesterday. Does she have constipation? That's under abnormal stool, if you're looking for that. Abnormal bowel sounds. Patient that uses laxatives. Some of these have drop downs. Here's an ostomy drop down, so if you need answers there. Urination. Has the patient been treated for a urinary tract infection in the past 14 days? Yes, because we're getting her with a UTI. Urinary incontinence, most of the time, yes, because this includes stress incontinence that we women get when you cough or sneeze, you leak a little bit, so yes. Bowel incontinence, we'll say no. Ostomy doesn't have one. We can go into genitourinary and address this UTI. SN to assess genitourinary status, identify any signs and symptoms of impaired genitourinary function. SN to instruct patient on UTI, including who to contact if signs and symptoms persist, blah, 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 blah. And you can come in here and teach on UTI. And you can make this specific for your patient. What exactly are you teaching them? And then down in goals, what is your goal? And they want a time frame. So for UTI, and you know, you would make it specific for your patient, and then within 5 weeks, you can see for this one, whatever. Okay. Again, medical necessity can be addressed here, and so can homebound status, but you don't have to, because you've already added at least one for each. Save and continue. Neuro, person, place, and time, or person and place but not time. Okay. Abnormal behavior, if the patient is irritable or if they're having hallucinations, could be related to the UTI, but you're going to document it here. Tremors, paresis or hemiplegia, dizziness is over here, spasticity, if I could speak, where is it? Forgetful, who said this patient's forgetful? Okay, and then you come down to this question, and this is new to the Oasis, and you can never hit no. Unless your patient is in a coma and his eyes are closed, you cannot hit no. You must hit yes. You're going to attempt to conduct an interview with all patients. So you can ask the patient, and this is on that sheet that we made up, 3 words. Can they remember? On the page, on this page it says repeat sock blue bed. You have them repeat that. Then you say, okay, remember those 3 words, and then you go on to ask them other questions. Time, the date, the president, whatever you want, and then confuse them by going back and say, what were those 3 things I wanted you to remember? And then you can answer this question. Okay, so you'll go through all of this. Let me just mark him here. Stage 2. She got that correct. Okay. Correct. Yes. Okay, and then it asks you, is there an acute onset of a change in her mental status? No or yes? Okay. Did she demonstrate being inattentive? No. Disorganized thinking, was her, she just rambling on? Say behavior not present. Altered level of consciousness? No. Cognitive functioning, patient's current day of assessment level of alertness, orientation, comprehension, concentration, and immediate memory for simple commands. Requires prompting in under stressful or unfamiliar conditions. When confused, maybe in a newer complex situation, but basically she's okay. When is she anxious? Usually all respiratory patients have some sort of anxiety, so maybe they're not anxious today, but sometimes they are. Okay, so don't give them a no, especially respiratory patients, because when they're short of breath, they get anxious. Emotional state. This tells you how to answer. So you ask it as little interest or pleasure in doing things. You ask the patient, do you find little interest or pleasure in doing things? They'll say yes or no. If it's no, fine. Symptom frequency will be never. If it's yes, is it 2 to 6 days a week? Is it every day, all day long, or only half a day? It's ridiculous the way they ask these questions, but anyway. And then, do you ever feel down, depressed, or hopeless? Yes or no? Okay, and then it gives you a score. And they'll say this patient is minimally depressed based on these questions. How often do you feel lonely or isolated from those around you? Well, a lot of times you get often, or sometimes, or they don't want to complain, so they say never. You might have to dig into that question a little bit. Behavioral status. Is there a memory deficit that they're unable to recognize familiar places or people? They forget events that happened within the last 24 hours? Yes or no? Impaired decision-making, failure to perform their ADLs, maybe. Verbally disruptive, are they yelling, threatening, excessive profanity, sexual references, physical aggression? You just answer based on your assessment of the patient. And then frequency of these disruptive behaviors. If you're going in to see a patient and the wife's like, oh, he hits me every day, well, that's a daily thing. But if nothing's going on, just put never. Plan of care, cognitive status, the patient's alert and oriented times 3, oriented to self only or oriented to self in place. Do they get agitated? Do they seem depressed, forgetful? You do not have to add this to your plan of care, but if you want to, you can add alteration in neurological status. So definitely for your Parkinson's patient, you're going to put something in here. If the patient has Alzheimer's, you can find that here. If you think there's a need for a psych nurse, this is how you generate that. Really what you do is you call and report to me and you say, I think this patient needs a psych nurse. And then I'll call the doctor and ask for that order. Psych nursing has their own little blurb here. It pops up. It's nice. Okay. Here. Moving on. Functional status. Patient might have poor balance because we're going to say that she's at risk for falls. Always. Parkinson's, maybe the shuffling of the gait. Limited range of motion. You might have somebody who's bedbound and they have contractures. They're going to ask you for the location. If you need to clarify anything, you can put it in the comment box. Then you get down to your MAC 10 fall risk assessment. This patient is greater than 65 years of age? Yes. Are there more than 3 medical diagnoses? Yes. Has the patient fallen within the past 3 months? Yes. Is the patient incontinent of urine? Yes. Does the patient wear glasses? Yes. Is there impaired functional mobility? The patient uses an assistive device and they have fallen, so yes. Environmental hazards. The minute there's an animal in the house, that's an environmental hazard because animals walk in between your feet all the time. So all you have to do is see a dog or a cat and it's yes to this. Another thing is that hard tile floor that they can fall and crack their head open on. Tubing for the oxygen concentrator. Of course, multiple medications, high-risk medications such as sedatives, antidepressants, tranquilizers, narcotics. Pain, they have pain, and she has a little bit of dementia, so we marked everything on her, so she's definitely at fall risk. This test is the click to assess up and go time, where you would have the patient get up from a sitting position, walk 3 meters, turn around, walk back, and you would time them. I never perform this test. I leave this for physical therapy to do. But if you want to do it, you certainly can. All right. Then we get into the mood questions. Grooming. This is where you want to put safely at the end of the statement. So grooming. Currently, the patient's ability to tend safely to personal hygiene needs, specifically washing face and hands, hair care, shaving, makeup, teeth, dentures, and fingernails. Okay. Safely. Can the patient get up from her bed, walk into the bathroom, unassisted, stand at the sink and wash her face, brush her teeth without any help? Most of the time, we're going to say the patient needs some help. Maybe grooming utensils must be in place within reach for them to be able to complete it, or they need some help from somebody handing them things or setting them up and then cleaning up the area. So we're going to mark this at 2. We don't want to mark this a 1 because if the patient is independent in this, do they really need nursing and physical therapy in the house? So we want to be able to show improvement from the start of care. We're going to mark it at 2. The patient needs some assistance with grooming, and maybe when we go into discharge, we're at just utensils in place or patient is independent. So we'll be able to show progression. current ability to dress upper body safely with or without dressing aids, including garments, undergarments, pullovers, front opening shirts and blouses, managing zippers, buttons, and snaps. Yeah, maybe she can put on her own shirt, but is she safe getting up from bed, walking to the closet, digging around the closet, pulling out her shirt, and then putting it on? So she needs some help. Someone to help her put on her clothing, or at least somebody to hand her her clothing. For her lower body, definitely if this is a 2, this is going to be a 2. If this is a 1, this could still be a 2 because it's a lot harder to put on your slacks than it is to put on a shirt. Bathing, current ability to wash entire body safely, entire body, including your feet. So could the patient stand in the shower, bend over and wash their feet? No. So we're going to say able to participate in bathing self in shower or tub, but requires presence of another person throughout the bath for assistance or supervision. Okay? Or able to bathe in the shower or tub with intermittent assistance of another person. And for intermittent supervision or encouragement or reminders to get in and out of the shower or tub, or for washing difficult areas. I'm going to put a 3 so that we can improve to a 2 or a 1. Okay. Toilet transferring, current ability to get in, to get to and from the toilet or bedside commode safely and transfer on and off. I'm always going to put reminders assisted or supervised by another, able to get to and from the toilet and transfer, unless they have to be wheeled to the toilet, picked up, put on the toilet, picked up, put that back down. Then I would put unable to get to the toilet or commode safely. Let's see, unable to get to and from the toilet or bedside commode, but is able to use a bedpan or urinal. So if they cannot get up and get onto the toilet or a bedside commode by themselves and they require assistance, it's going to be one of these 2. And if it's a bedbound patient or an incontinent patient, it's going to be dependent, totally dependent. Okay. Toilet hygiene, can they appropriately clean themselves after using the bathroom? Usually, they can urinate and wipe okay, but not everybody can clean themselves properly after having a bowel movement, so someone might be needed to help maintain hygiene. Transferring, the patient is able to jump up from a chair and walk across the room and sit down in another chair. That's probably never going to be one of our patients. We should never hit a 0. Able to transfer with minimal assistance or the use of assistive device. Okay, that one. Or able to bear weight and pivot during the transfer process, but unable to transfer self. So for this patient, we're going to put a 1. But for the patient that is in a wheelchair, maybe they have an aid that helps them go from the wheelchair to a chair. Maybe they can stand up and pivot, but they're not going to be walking across the room. So read into the question, because you want to make it as bad as possible without lying, but you don't want to make the patient sound like they're independent. So, ambulation, locomotion, current ability to walk safely, once in a standing position, or use of a wheelchair, once in a seated position on a variety of surfaces. So if the patient has poor balance, yeah, they can get up, but are they safe walking across the room? Or should they have a 2-handed device, or should there be somebody standing by them at all times? So it just depends on your patient what you answer there. And then of course there's chair bound and bed bound. Feeding or eating, current ability to feed self meals, snacks safely. Then they confuse you by putting, this refers only to the process of eating, chewing, and swallowing, not preparing the food to be eaten. But if you read this, it says able to feed self independently, but requires meal setup or intermittent assistance. So most of my patients are this, unless they aren't feeding themselves, and I'll mark something down here. But I don't want to say the patient is independent feeding when there's a caregiver in the house that's helping set this stuff up. Okay? So functional limitations, bladder incontinence, ambulation, hearing deficit, we said she had hearing aids, she's short of breath with moderate exertion, she has a vision deficit. So those are all functional limitations we want to mark. And then the plan of care activities permitted, restricted, up as tolerated, human assistance required, she has a walker. And then we're going to have PT come in, so we would put exercise prescribed. Need for fall prevention plan. We want to definitely add fall prevention to the plan of care because she's a high risk for falls. Patient identified to be a high risk for falls. SN to provide skilled assessment, identify, mitigate risk factors, provide instruction and reinforcement of teaching to prevent falls and injury. SN to instruct patient or caregiver. I'm going to get rid of that caregiver. On fall prevention as well as a need for therapy services. We want a patient free of falls and injury during the assessment. I always put patient wears appropriate footwear. If the patient is diabetic and you catch them walking around barefoot, you're going to teach them about diabetic foot care and ask them to get sneakers. Patient to wear appropriate footwear to prevent falls, and I'll say within 2 weeks. You can put within 2 days though. Patient will wear appropriate footwear when ambulating. We can put when ambulating. To prevent falls within 2 weeks or 2 visits. Say 2 visits. Because you can always go in your care plan and in 2 visits the patient's not cooperating and not doing that, so you can address that again. Clear pathways. I've always changed this to say patient will get rid of this stuff. Will maintain clear pathways throughout episode care. Now you could keep the statement the way they had it, and you can put, maybe you go in and the walkway is very shallow and you tell the patient, I would like you to have your son move that dining room table closer to that far wall. So then you could say patient will clear pathways within, will show clear pathways within 1 week by asking her son to move the table closer to the wall. And once it's done, then that is completed. All right. The other thing is adequate lighting. I changed this and I put patient's home will be equipped with adequate lighting throughout episode of care. Whoops. Okay. If there's an animal, I always mark this patient understands risk with pets. Patient will verbalize understanding of risks with pets. Because I'm going to say, you know what, I love your dog, but he peed on the floor. That makes the floor slippery. So we need to point that out and make sure that they understand they need to watch for that. Or the dog's running in between their legs or jumping on them. So, and then we have patient will be free from falls. Okay, so then we'll save and continue. This is functional abilities. This first part is indicate the patient's usual ability with everyday activities prior to this illness, exacerbation, or injury. So maybe the patient was totally independent before she went to the hospital and now you're ordered. So if that makes sense for the patient, self-care was independent, indoor mobility. Maybe she wasn't independent, maybe she needed some help, she had an assistive device. Maybe she was able to go downstairs by herself, but I doubt it, so we'll need some help. And then functional cognition, maybe she was independent before this illness, so you could have that. Was there a prior use of assistive device? We're going to say yes, walker. So now you're going to code the patient's usual performance at start of care, or the rock, whichever you're doing, for each activity using a 6-point scale. If the activity was not attempted at start of care, code the reason. So the first one, I don't like to fill it out and have it drop down everything. I go through it independently. The ability to use suitable utensils to bring food and liquid to mouth, swallow, and or liquid once the meal is placed before the patient. This one, I always, if I'm saying that the patient needs help preparing meals and stuff, I'm going to put clean up and set up. Yeah, they can feed themselves, but they need somebody to set it up for them and clean up. Oral hygiene, we said that she needed some help performing oral hygiene, grooming I think it was. So we're going to put supervision or touching assistance. Toileting, same thing, supervision or touching. Showering, I'm going to say partial to moderate. Upper body, we can say supervision and touching. Lower body, we'll say partial or moderate. And putting on and taking off her shoes, she needs help bending over and do that, so we'll put partial or moderate. These are what you've coded at the start of care. So each Oasis you do after that, you can improve upon them, but what really matters is from the start of care to discharge. We need to show improvement, or things are staying stable, but we'd like to see improvement. Mobility, same thing. You're going to read through it. When the patient, and it's on the cheat sheet that we showed you in the beginning that's attached. So when you're doing your assessment, if you fill out everything on the cheat sheet, it's all there for you. And we said, okay, the patient can lay in bed and roll back and forth right to left. So we can do that independently. But she can't go from a sitting to a lying position independently. She can't put her feet up. So this, definitely we're going to say she needs assistance. Can she go from a lying to a sitting on the side of the bed? Well, she needs assistance. Sitting to standing needs assistance. Chair to chair transfer, she needs standby assistance. Toileting transfer, we said she needs assistance. Car transfer, yeah, she needs assistance. Walking 10 feet, supervision or touching assistance. 50 feet in a turn, maybe she can get away with supervision and touching. Walking 150 feet, maybe you say, no, she can't do that. She would need to have somebody holding on to her. Definitely for walking on uneven surfaces, partial and moderate. Can she go down the curb 1 step, maybe with assistance? 4 steps? Well, there weren't 4 steps for me to test her on, so I'm going to put not attempted due to environmental limitations. I wasn't able to test her on that. And same thing would go with 12 steps if you were answering that. Because you answered that, it knows not to ask you that next question, so it disappeared. It takes us down to picking up an object. This means, can the patient stand and then bend over or stoop over from a standing position to pick up a small object such as a spoon safely? No. So we're going to say no, she would need assistance. And then, does the patient have a wheelchair or walker? No. If you're going to ask for therapy, this is where you indicate that. Yes, we want physical therapy. Physical therapy to treat and evaluate the patient. That's your intervention. And that little statement comes in here. That statement is fine. Then your goal. Physical therapy evaluation will be performed, and a plan of care to increase functional independence will be established and countersigned by a physician. You can leave that statement. When you add a therapy, you need to add a medical necessity and a homebound statement so that it shows up on the plan of care. So we'll go to strength and physical endurance. Patient requires skilled intervention of physical therapy to exercises to increase strength and endurance, implementation of safety measures, and evaluate for assistive devices due to impaired function or declining function as demonstrated by, and if you know the patient fell, you can put as demonstrated by recent fall. I'm going to put increased weakness and recent fall. Okay. Then you're going to go down here to where it says teach and train physical therapy. Patient requires skilled intervention of physical therapy to teach and train. We're going to get rid of caregiver and asterisk. On exercises to increase strength and endurance, implementation of safety measures, and use of assistive device due to impaired function or declining functional ability to perform ADLs. Then I'm just going to get rid of this last one. If there's nothing I want to add, that's fine. So we've added physical therapy. Here, I might want to go in here, and I have a template made up for homebound status, right here. And it puts it in here, and it says homebound, yes, patient is confined because of illness, needs the aid of supportive devices such as, and I can put a walker, the use of special transportation or the assistance of another person in order to leave their place of residence. Patient has a normal inability to leave home, and leaving home requires considerable and taxing effort for the patient. Specifically, the patient has significant disability related to, and we'll say shortness of breath from her COPD. Patient requires the use of a walker. However, ambulation is quite unsafe and slow. And then you can get rid of this unless you have something you want to put in there. Patient requires assistance with ADLs and one person assists to leave home. Okay, and that's a good homebound statement for just about almost all of our patients. You can adjust it to meet their needs. Save and continue. Still there?
We're still here.
Okay.
Sure.
All right.
Miss Laura?
Yes, ma'am.
Yes, before we move on, in a situation that they have the PT order in place, are we still going to fill in all the section that you just showed?
Yes, because if you're the nurse doing the start of care, you are adding PT to the plan of care, and then PT goes out and does their own assessment, and then their stuff transfers in, but you have to have PT being ordered under the nursing care plan.
Okay.
Then they have their own section of the care plan that we don't touch, but you putting it on there puts it on the 485 for the doctor to sign.
All right. Thank you.
Yep. And an endocrine and hematological, this patient has diabetes. If they have hypothyroidism or cancer anemia, we would indicate it, but we know she has diabetes. Blood sugars are performed by, now, some diabetics don't ever test their blood sugar and they wait to go to the doctor. So here you could put caregiver or patient if she's doing it herself. So I would put caregiver if she goes to the doctor, she's not testing. This says patient's fasting blood sugars from the log machine or report. So if you know what her range is, you can put it in there. I always just put the normal range here, 70 to 120, and random 70 to 200. Now if I had a log to look at or the machine tells me what the ranges are, I would change it in here, but otherwise I just put what the normal range would be. Patient's blood sugar status unknown because there's no glucometer, paper logs, visit reports, or patient's ability to report, so I would put that. Blood sugar status unknown reason, patient does not test. Okay, or if you do have that information, you can fill out what pops up there, okay? Were there any signs and symptoms of hyperglycemia, hypoglycemia? Is diabetic foot care not being followed? The patient's walking around in bare feet, the toenails are an inch long. You know, if you think that there's a problem there, indicate that there. And then diabetic management, the patient's diabetes is being managed by oral hypoglycemics or insulin, diet and exercise. A lot of times you'll see patients with diabetic, there's not one diabetic med on the MAR, so I guess it's just diet and exercise. So on this patient, I put insulin just so you could see how we put it in the MAR. So insulin administration, we'll just say Novolog. Insulin per sliding scale. And then once we do the med profile, we'll put the sliding scale in. Insulin administered by a patient, caregiver, SN to administer. We only have, oh, he wants to go. Excuse me for 1 second. Open the door before he walks away. The shred guy's here. He's gonna use the elevator, so hold on 1 second.
Jamie or Jamie Cook?
Hold on 1 second. Hey, Jamie.
Thank you.
We're almost at the end of the assessment. I mean, the Oasis stuff. Yep, okay. Okay, bye. Here. Oh, it's upstairs, so we have to bring it down. Bring it down, bring it down. Yeah, hit the bottom. The bottom.
Oh, this is sad. This is sad.
Yeah, but, oh, I see what you're saying. Where's the key?
Oh, yeah, it's full of stuff.
Let me run upstairs. Hold on 1 second. Talk.
Thank you.
Hope you girls learning something.
Yes, Michelle, nice to hear you again.
You're not, I know, you're not sleeping, are you?
Where are we?
Huh? Y'all good?
I said we are away.
Okay. It'll be a few minutes.
The door needs to be closed, good.
says fixture of everything, so that's why I have to go every time something happens. Okay, so if it's a diabetic patient that we're going out to see, and we only have 2 of them, one's in the rehab right now, but we don't take dailies very often. So if the nurse is going out, this is where you would mark that the nurse is going out to either train a caregiver, there's cognitive deficits, so the patient can't do it themselves, whatever. Poor vision, yeah. No willing or available caregiver, you can mark there too. And then if you're taking care of diabetes, you want to put that on the care plan. So we'll put alteration in glucose metabolism, SN, to assess diabetic status, identify signs and symptoms of impaired diabetic function, report significant changes to physician. And then you could teach on diabetes and say that you're going to teach insulin injection to the patient, or you can put that you're going to administer insulin to the patient for a sliding scale, or you're gonna, well, we don't usually do that, pre-filled syringes, but whatever. You're gonna perform the finger stick, or now they have those nice ones where they have it stays in for 14 days, those are nice. So based on your patient, you will adjust this stuff, and then your goal will be to demonstrate competence. The patient can demonstrate competence with self-management. No, that's not gonna happen, or maybe it will. Minimize long-term diabetic complications. You can adjust that, just add something here for the care plan so that whoever's going in to see the patient has something to document on in the plan of care. So we'll put this first one, patient will demonstrate competence in self-management of diabetes. Evidence by adherence to medication regime, ability to identify signs and symptoms necessitating contact with medical professionals, diet regime guidelines, activity compliance, and symptom management. We can put in here within, 8 weeks. 8 or 9 weeks. 9 weeks is the cert period. This could be one of our long-term goals, okay? And there's other things that you can mark here. If you wanted to add a medical necessity, you could, or homebound, but you already have that, so you don't have to. Okay, let's continue on. And you see we're all the way down here now in nutrition. So the patient might not have any problems eating. There is an illness or condition that the patient dictates the type of food they're supposed to eat. That would be the diabetes. Even if they're not on a diabetic diet, you would say that they should be following a no concentrated sweet diet. So therefore, number 10 is should be marked. And then the patient has a wound, so that's something that we should mark. And then patient takes more than 3 meds, prescribed or over the counter, you mark there. And then anything else, if the patient was losing weight or gaining weight, or they're not eating 3 times a day, you can mark that. Gives you a total of 25, and that puts the patient in good nutritional status, 0 to 25. If it's moderate or a high nutritional risk, you might want to add that patient to the care plan under alteration in nutrition. Okay, but we won't do that right now. Patients, nutritional approaches. No. Mechanical altered diet, no. Therapeutic diet. I'm going to hit yes because we're going to say it's a diabetic, so it should be a no concentrated sweet diet. Even though it's not a technical prescribed diet like a whatever calorie diet, this you would put no concentrated sweets as a therapeutic diet. Okay? And then you hit no concentrated sweets. You could also say she has hypertension, so no added salt. Rarely are we going to have regular diets, especially not with diabetic. You have to mark something. Hold on 1 second.
You're gonna do the magic.
What?
I left her. I'm over there, she's coming out from the
Oh,
bathroom.
okay.
You had two in this, two here,
Okay.
right? Initial from here, signature from them,
What do you want, blood too?
signature from them.
You want blood?
Blood, not yet.
Oh, I can't write right now. My
What?
hand's like in a spasm.
I just gave a blood a few days ago.
I can't write. Look at my handwriting. It's terrible.
What's going
I don't
on?
know. My hand hurts.
Oh, man,
All right.
my muscles, my joint.
Okay. All right. So then you
Just
could.
have a good day.
Good day.
Thank
You could
you.
add this to your time share, but we're not going to. We're gonna go save and continue. Now you get to your medication profile, this little black box up here. Click on that, and that brings you to an empty profile. And the only reason it's empty is because I emptied it out today. You did your started care, so you have your med list. So the way you add a med is to go into add medication. And if it's a long-standing med, or if it's a new med, depending. So we're gonna say this is a new one, this is the antibiotic. We're gonna say she started the antibiotic today. You'll type in the name of the medicine, and then, just the name, and then you search for the medication. This pulls up the formulary for Axxess. They recently updated their formulary. When you pick the meds out of the formulary, then you're able to run drug interactions on your meds. If you have to type in a med that doesn't show up on the formulary, that med will not be included in drug interactions. I'll show you. So we've added Levaquin. It's 1 tablet. And the doctor that ordered it is her doctor. Its frequency is twice, or every 12 hours. And it's for 7 days.
Sabrina.
Okay, so I put an indication on every med. I try to. So we definitely, for an antibiotic, you're going to want to put an indication. Any PRN meds have to have an indication. So if there's Tylenol on the med profile, you have to have an indication for fever or pain or something. Okay? And then its route is PO, and that should give you a drop down, and there you go. And this is a new med that she's starting, so you have new here. If it wasn't a med that was new, you could have changed or unchanged. And then here, if you do not, you want to click here if the new medications were found in the home, and you do not need to write an order. If you go into the house and the patient says, the doctor told me to start using Valtorin on my knees, you would have to click here and that would generate an order. We'll write one so you see it. But for right now, this is okay. So you added your first med, save, and add another. Okay, so we'll say she's on long-standing aspirin patient. We type in aspirin, we search for the med, we find it here, 1 tablet or 1 chewable. Okay, the doctor, let's say daily. All right. Here we'll say, okay, and the route, PO, or chewable, whatever, PO, and it's unchanged, she's been taking it, okay? And we'll hit save. You can hit save and close and go back to your meds, you know, take a phone call or whatever. Then you go right back into it. And now we'll say there's been a change in meds. So she was on gabapentin before she went to the hospital, but now the doctor changed the gabapentin, so we'll say search for it. And it's 100 milligrams capsule, okay. 1 capsule. And before she took it twice a day, and now she's taking it 3 times a day. So we're gonna go ahead and put every 8 hours. Neuropathy. And PO. And it's a changed med, okay? Save and add another, so it shows up here. Now we're going to say, let me see, we'll use my example of Voltaren. Okay, we'll put hope I spelled it right. Okay, here's your Voltaren, and we'll say for creams and gels and stuff, I usually put small amount, or you can put 1 application. The doctor, this is PRN, we'll say, and it's apply to bilateral knees 3 times as needed. Or and it's topical. We'll say she just told us about that, there's no script written, so we're going to click here to generate an order, okay? So for right now, we're just going to continue on, save, okay? And the next med we're going to put in here is one that you probably won't find in the formulary, so let's try. We'll say it's new. 6, let's say oxygen. Search. Oh, it came up as this. This doesn't help us at all. So we'll keep oxygen and we'll put 2. And I'll put respiratory agent. And then you can go to, here's the nasal cannula. Breath. Okay, and or we could do inflation. And, oops. Okay, and we could create an order there too, because it's new. Let's see. Okay, and I'm not going to do one, but I'm just going to tell you. If you do a sliding scale, or if you have a sliding scale, you have to write it out in here. So you would add the insulin, and you would put per sliding scale, and then you would write out the sliding scale, so it would show up on the mark, okay? Once you're all done putting your meds in, you want to run drug interactions. And see, the only drug I didn't pull out of the formulary was the oxygen. So that is not going to run against these medications for interactions. So just remember that. If you see drugs up here, like Tylenol, aspirin, you didn't pick it out of the formulary. So you need to go back and do it through the formulary so that it will run against all the other meds for interactions. Oxygen, we know, is not going to interact with any of these things. So once you have your list, you'll click to check everything and check interactions. It will tell you if there are any interactions. This one only has a minor interaction between the aspirin and the Voltaren. and it's minor. We don't really worry too much about minor and moderate. But when you get a severe reaction, like if you had Coumadin and Xarelto on the med profile, it would probably pop up as major. That's something you want to make sure you tell me, because I'll print it out and I'll send it to the doctor. Saying that though, I'm gonna say if you are readmitting a patient you had before and you remember that was on there before, we don't have to send it again. We've already addressed it. So, but if it's something new, definitely let me know and we'll print it out and send it to the doctor. They may say, yeah, we know about it, leave it alone. That's fine, but at least we took care of it, okay? Once you've run your drug interactions, you can sign your med profile. This is where you sign. This is where you look to see if you've signed it, because you know, you sign it, you might, did I sign that? So you can look there. But this is where you sign it. So you run your interactions, you sign it, and then you put the date of the start of care, the date of the visit, and sign. And now it's going to say medications have been added. Hold on one second. This is Laura.
Yeah.
Yes, I am, but I'll step outside real quick. You ready?
How do we get a picture on here? I don't think that's just yeah. You use your phone. So is that HIPAA protected? Because we have the patient's information and that's a personal phone. And so I need that to answer that question. Okay. Ẹ máa ti stop ó yà kó wo screen pẹ́ náwó. Right, for so long. You know, and I didn't want her to just go through without addressing. But I tell you, she had one woman for any customers in the blood pressure. She won't or you won't do it. No, the one is from them, but the blood pressure machine, I have it. The blood pressure machine, I have the glucometer, the money stethoscope, but the dressing, our mama provided the gloves and stuff. I feel very supposed Then for a start of care, okay, so money pay okay, but yeah, start of care or a continuation of care, okay, a minimum of an hour or 2 hours. Because no, that you have to record. It's not what you have to use in the patient's house. But you have to so by the patient's house, to buy 2 hours. Okay. Hi, Laura.
Hi, okay, sorry.
Hi, Laura.
Hi.
Hi, I do have a question
Okay,
for you.
go ahead.
So I think it's in terms of the one. So if we have to take the pictures and let it reflect in the voices, do we take the picture with our personal phone and is that HIPAA protected?
Yeah. It is not. We tried to get the owners of the company, Jamie did, to buy a protected, whatever you call it, and he wouldn't go for it. So even if you use your tablet or laptop, we don't have a protected thing. So what I ask you to do is to take a picture and just send it to me, and then I'll put it in and then get rid of it. And be specific.
So do I send it to your phone, even with the patient's information?
You'll send it to my phone. I'll give you my cell phone number. And then once I put it in the computer, I'll delete it. Once you send it to me, you delete it. Get rid of it. Okay? And then when you send it to me, I need you to be very specific on what I'm looking at. Because sometimes you'll take a picture and you'll know what it is, but I don't know if it's the left leg, the right arm, the back. So let me know exactly where the wound is and the measurements, and then I'll put it in your note for you until you get used to doing it and figure out how to do it in the field. Okay? All right. All right, so then in the med profile, you see it came up, it says create order for medications. There are 2 meds in there that we indicated we needed an order for. So I'll go create order. It has the date and time here. The summary is going to be just medications, med order, medications. And the meds are already here, it put them in there. There's the Voltaren and the oxygen. And then I'm gonna sign it, it's already dated, put a time, and I'm gonna create the order, so. Create the order, and now it becomes part of the chart. QA is gonna look at it and then send it out to the doctor, and then we'll get it back signed. So if you're like, oh, did I sign? I can look over here and see that I signed the profile up here. Okay. Then we can get out of meds. If I gave any meds during my visit, I would indicate it here. Down here under medication status, I would say meds were reconciled. Medication issues identified, if there were any adverse or drug interactions that were serious, I would indicate them here. We check that, and then it asks you to name the drugs that have the interaction problem. Okay? So no issues. If the patient is using an anticoagulant, you would put that here. Aspirin doesn't count, so if there's Eliquis or Coumadin or Apixaban or whatever else, you would indicate it there. If there's insulin, this is for pre-filled syringes. I've never done a pre-filled syringe for a patient. It's usually we go out and give the insulin, so I've never marked that. If there's an IV, you document that here. Then you come down to pharmacy box, and I had already put this in. The patient's pharmacy is ABCD pharmacy, but if we didn't know, say the patient says, oh, I use CVS. I can type in CVS, and the CVS's that we've already put in there show up, and if you can find it, fine. But this patient is ABCD. Okay. If you need to add a pharmacy, say there's a new pharmacy, you'll go ahead and put, you'll go ahead and put, we'll say, DEF pharmacy. Deaf pharmacy. And then their phone number. And our state, save, and then if you needed to add a new pharmacy, you could put DEF, they would show up, and you could pick them. We don't need them, get rid of them. Okay, this ABCD pharmacy, save. Then, once you've added your pharmacy, if you want to go back and look at your med profile, the pharmacy shows up here with a phone number, okay? All right. So the next question is drug regime review. Did a complete drug regime review identify potentially clinically significant medication issues? We'll say no. If it was yes, has the patient or caregiver received instruction on special precautions for all high-risk medications? The patient has, yes. We talked about the insulin. Management. Is the patient able to take meds by themselves? No. Is the patient able to take medications if individual doses are prepared in advance? You would use this for those pill boxes that we use. If the patient is a management patient and we're just filling a pill box, you can use that. If the patient requires somebody to actually give them their meds at the correct time, you would use this or this. Okay. So we'll say this. Is the patient able to give themselves injectables? what's the dance you're doing? Okay. Able to independently take the correct medications, proper doses at the correct times? No. Able to take injectables at the correct times if syringes are prepared in advance? Able to take medications at the correct times if reminders are given based on frequency of the injection, or unable to take injectable medications unless administered by another person. If we're going out to do diabetic management every day, then this will be this. High-risk use drug classes. Is the patient taking an anticoagulant, antiplatelet, an antibiotic? Yes. This patient takes insulin, and it asks for, is there an indication noted? Yes. So if they check in the chart, they'll find out why they're taking those meds. If the patient was on tramadol or oxy or something, you would mark that. Or if they're not taking any of those kind of meds, you can hit none of the above. Orders for discipline and treatment, we want to say med management. The patient, this is going into the care plan. Patient medications were reviewed and reconciled. So SN to perform medication review each skilled nursing visit and reconcile medications as indicated. SN to instruct on all new and changed medications and reinforce teaching related to the use of medications as part of the disease process or demonstration of knowledge deficit. You can leave that statement, or you can change it to something like SN to instruct patient on new med, Eliquis, SN to instruct on possible adverse reactions, side effects, blah, 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 and you can individualize it for your patient, which the surveyors love, which is what we got hit on because we weren't individualizing the care plans enough. So really, it could be as easy as saying, SN will teach patient how to fill their weekly med box within 3 weeks. And then on week 3, SN is required to teach, to continue med teaching with patient with weekly med box for another week. You know, and then you get to the 4th week and you say patient is able to fill weekly med box independently, no further nursing needed. They love that stuff when it's that individualized. So, all right. So if you're doing weekly med management with a pill box, you would mark here. Okay. And then the goal is the managed medication regime. Patient demonstrates ability to effectively manage med regime by 2 weeks, or you could put medication regime compliance. Patient will demonstrate compliance with medication regime as evidenced by correct administration, reporting side effects or adverse reactions within a certain amount of time. If you're doing weekly med management, you can say patient will demonstrate compliance with medication regime as evidenced by an empty pill box weekly. So you can do that. Very rarely do we do PT-INRs, but if somebody was on Coumadin, they might be, PT-INRs might need to be on your plan of care, and that's where you find that. Just gonna get rid of this and put within. Again, medical necessity shows up. Homebound status, you do not need to add them. You've already added them, so you're good. Care management. Types and sources of assistance. Determine the ability and willingness of non-agency caregivers, such as family members, friends, or private caregivers, to provide assistance for the following activities. Supervision and safety. Patient lives alone, doesn't have any family, so we'll say assistance needed, but no non-agency caregivers available. Okay? Supplies. The patient has a walker in the house. They also have oxygen. They have a shower bench and grab bars. If there is oxygen, who provides it. There'll be a sticker on the concentrator. You write out who they are and their phone number, because when hurricane time comes, guess who we're calling to make sure that the patient has plenty of oxygen in the house. Also, when the nasal cannula is all gooky and they need a replacement, we need to be able to, so you can look up and call and say, hey, they need more supplies. Okay? You will never have to fill out an aid care plan. When you call report to me, if you think they need an aid for bath visits, you'll let me know and I'll do the aid care plan. The reason why is because we use our sister company, First Light, to supply our aids, and the owners have decided that they want a very generic care plan. So I put it together and then Michelle manages it with the aids, so you never have to fill this out. However, if you think the patient needs an aid and you call me and we say, yeah, we can give them an aid, then you're gonna add HHA to the care plan, need for home health aid, for safe and effective personal care, and the patient will be free of injury and free of skin breakdown. Let's say free of further skin breakdown, because there's already a wound. And then under medical necessity, you'll say requires home health aid. Patient requires services of a home health aide under the supervision of a skilled professional to assist or assist patient. Caregiver, there's no caregiver here. With personal, that was me. With personal care and ADLs due to, I'm going to put increased weakness and recent fall. There it is. Okay. And then that puts that aid on your 485 that goes to the doctor. Okay? But as far as the aid care plan goes, I'll fill that out. All right. And then summary of care, physician visit information. If you know when the last time they saw their doctor was, you can put that in there. So the face-to-face is complete. Again, don't worry about that. We'll handle that through QA. Lab and infection control. If you get a urine specimen, if the doctor tells you to get a urine specimen, you can mark that here. And whether it was collected via the catheter or an in and out catheterization or a clean catch. And also, where was it? Okay. We'll say urinalysis obtained. And then under other, you have sputum, wound culture collected, stool sample, whatever. We hardly ever do that. We don't normally do any collection except urine. If we need blood, we have a mobile phlebotomist. His name is William. We call him and he goes out the next day and draws the blood. His lab runs the test and then we get it and send it to the doctor. If it's in a facility, though, the facilities have their own people. I don't know what Oakmont does. I know Horizon Club has their own lab they use, and we don't have to do that. So it just depends where you are.
Oakmont have their whole lab person that comes in to draw the lab.
Perfect. So that you won't need to worry about that. Okay, so labs and a universal precautions observed. If you are starting a patient who is not on an antibiotic and diagnosed with a UTI.
Primary Tarian, AARN.
I'm sorry, that's my doctor. Hold on. This is Laura. Some days, nobody calls me. Other days, everybody calls me. Okay. So, okay, patient rights, patient areas of interest. If you're teaching on meds, you can put how to take your meds, what to eat for diabetics, activity and exercise, how to manage your symptoms, when to seek help, and how to stay out of the hospital. It's really important that we educate the patient that they are on home health with nurses who should be called when they're having a problem. Now granted, if you're having chest pain, you go to the hospital right away, but if you're not feeling well, you don't cancel your visit with the home health people. You know, we need to teach them that. We get so many calls, oh, I'm not feeling well today, can you tell the nurse not to come? And I'm like, no, that's when the nurse needs to come. So we gotta, educate patients about that. It's a bad habit that they have. All right, and then you're gonna ask the patient, what are your goals for having home health? And obviously, if it's a wound care patient, it's gonna be to heal the wound. Or I want to try and stay out of the hospital. This area has to be answered in the patient's own words. So if you say, what are your goals for having home health? And they say, I want this dam. I spelled dam. I don't even know.
D-A-M-N.
I want, wait a minute. Putting slang here. I want this damn wound to heal. That's what you're gonna put then. They wanna know that you asked the patient the question and you wrote down exactly what they said. If you say something like, I'm hoping to achieve medical blah, 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 they're gonna know that the patient didn't say that. They want it in the patient's own words. Even if it's cursing, and go ahead and put it there. All right, and then coordination of care. You're going to call report to me, and maybe there's an LPN also in there, and there's going to be a physical therapist in there, and then the physician. And if there's going to be an aide, there's an aide. So these are all the people that we coordinated care with. Nursing wise, you're going to put my name, and say you're going to have Penny DiPietro. I don't even know how to spell her name. DiPietro. Follow the patient, and you spoke to John Smith, the PT, and Dr. Bradford, this patient's primary care. So care coordination was between nursing, PT, the home health aide, and the physician. Let me add the aide in here. All right, all these people are part of this patient's care, and even if you didn't talk to all these people, you're going to write down their names as part of care coordination, and you can put start of care completed. You are technically supposed to call the doctor every time you do a start of care to do your med reconciliation with him. However, we know that when you call the doctor, you're not going to get the doctor. You're going to get either the office manager or the receptionist at the front desk, and they're going to say, oh, I'll take a message and have him call you. Well, it doesn't help for him to call you 3 hours from now. So we're going to send him the 485 that you generate as the orders, and he'll sign them. So that's where our communication with the doctor is. Now, if you go out and you think the patient's having an allergic reaction to the antibiotic, sure, you're going to call the doctor and you're going to document it. But if we call the doctor every time we did a start of care and said, oh, I'm calling to let him know I did a start of care and I want to reconcile the meds, you're not going to get anywhere. So, problems, yes, call the doctor. All right, so our care coordination was about the fact that started care was completed. If the patient falls when you're in the house, if the patient tells you, oh, I'm glad you're here, I fell a half hour ago. You didn't see the fall, maybe the patient didn't even get hurt, but now they're telling you about a fall, you're gonna do an incident report. Patient's name, the episode of care, the date of the incident, just so you know it's here. If it ever happens, you can call me and we'll go through it together, but it's right here, you can generate it. Plan of care review, yes, you developed and reviewed the plan of care and the goals with the patient, always. If the patient's not capable of doing that, was there a representative there that you went through everything? We're gonna do this with the wound, you need to make sure you turn the patient, you're reviewing the plan of care and the goals with the patient. Or if there's nobody with the patient, but you called the POA to get permission to go see the patient, you can mark the legal representative, okay? Patient response, the patient has barriers impeding full participation. She can't reach around and do her sacral wound, so she agrees with the identified goals, but she's not going to be able to participate in that problem. What? Oh, okay. If the patient is not able to participate and they don't agree with the goals, you can always talk to the legal representative and explain to them what we're planning to do and then whether or not they agree. Emergency contacts, if there happens to be a daughter that calls while you're there and you know we don't have her information, you can add her on as an emergency contact. So all you do is click on emergency contacts, it brings you here. We have Dan Smith, the son, in there, but we want to add another one. Add emergency contact, Joan, whoever, Collins. And she's the daughter, and she gives us her phone number. And maybe she gives us an email address, and then we can add her as an emergency contact. Oops, I added another one. There we go, save and exit. Okay. Patient strengths, is the patient a motivated learner? Some patients are demented, they're not gonna learn anything that we teach them. Strong support system, yeah, they have a good caregiver. If it applies, mark it. Reviewed and or instructed on the following. Never hit NA. When we do the starter care, we review all of this. The patient's rights and responsibilities, it's part of the starter care pack, and you sign that you gave that to them. Okay, on here, what it wants you to do is to get rid of these asterisks, and you can either say patient selected representative, or legal representative received the written patient rights and responsibilities in a language that they can understand, okay? And then engage the patient or representative in discussion, that one's okay. Oral communication of patient rights and responsibilities, and I always change this to say has been completed. Because when you go over the folder, patient rights and responsibilities in there. So you've taken care of this. Oral communication of patient rights and responsibilities has been completed. Okay. Then I don't know anyone that would deny a copy of the notice of rights, so you're never going to hit that. Patient was informed of the home health agency's policies for transfer and discharge. We need to let the patients know that they are on service with Seaside Home Health. When they go to the hospital, we need to know. Sorry. Let me get rid of this. Patient has been informed of the home health agency's been informed of the home health agency's policies for transfer and discharge. Patient needs to be notified at least 2 days before we discharge. So if you're planning today that your next visit is gonna be your discharge, you're gonna tell the patient, on my next visit, we're gonna discharge you. Your wound is healed, you'll be ready for discharge. Okay? And then on the day of discharge, you have to reiterate, you are being discharged, either just from nursing and you'll continue with physical therapy, or you're being discharged from all of your services today, so they know nobody's coming out, okay? Patient was informed of the contact information for the appropriately funded and state-funded entities. We're a Medicare agency, so we have to notify the patient that we are a Medicare agency. We're regulated by ACA, and I believe all that's in the folder if they wanted to call anyone, and we have to tell them about the abuse hotline too, that's in the folder. Patient was informed of contact information for the home health administrator, that's Jamie, and her phone number is in the folder, along with mine. Okay. Medications were reviewed, performed complete medication review, and assessed drug interactions. The disease process was instructed. Safety was instructed to prevent falls and infection control. Safety measures, disciplines, and scheduling was discussed with the patient. The patient knows that they're getting nursing and physical therapy, or nursing, physical therapy, and guess what? Now you're going to get an aide who's going to come out and help you take a shower, and we're going to send a social worker too. So that way they know who's going to be contacting them. And then you always put that you contacted the physician regarding the initiation of home care services per physician orders with a plan of care to follow. Okay? Then, interventions are things that you did while you were in the home. So if the patient has a wound, you're going to say SN completed wound care to sacrum per physician's orders, or you can go ahead and go back and copy it and paste it in here. Physician's orders. SN reviewed all of patients' medications. That's everything you did. An intervention is everything you did while you were with the patient. And then the next one is the response to your teaching or procedure. Patient tolerated wound care with minimal discomfort. Wound appears infection-free. Patient verbalized understanding of half the medications that we reviewed. Ongoing teaching is needed. That's what the response to your teaching or procedure is. This is what you did, this was the response to it, okay? Patient needs further instruction. Okay. Then you get to your admission summary, face-to-face addendum. Don't worry about that part. Your visit narrative does not have to be 6 pages long. I did put a template in here if you want to use it. There's a couple of them. I use the COVID patient identified. So I click on that one. And I'm going to change this to SN start of care assessment. And then SN wore a surgical mask, whatever you do when you go in to see a patient. I still wear a mask because I don't trust any of them. They lie and say they're not sick, and then I get COVID. So I wear a mask. I wear my gloves. When I need to, I wash my hands. So I'm documenting that, and then I'm documenting that I identified the patient by name, facial recognition, whatever. Then you're going to put in here just a little basic report. Patient is a 78-year-old female, recent hospitalization for uncontrolled diabetes and sacral wound. Patient has a history of blah, 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 blah. Start of care orders received from Dr. Bradshaw or Bradford, whatever. Patient will require skilled nursing for wound care and diabetic teaching. Patient will require physical therapy, eval, and treat for increased weakness and recent fall, and home health aid indicated for assistance with ADLs, including bathing. Boom, that's it, done. You've written your addendum, everyone knows what's gonna happen in there, okay? Then you have plan of care, discipline and orders, treatment, skilled nurse evaluation performed, need for skilled nursing services. So plan of care, SN orders, locator. This is when nursing went into the start of care and nursing is going to be indicated. For your therapy only cases, skilled nurse evaluation performed, no further visits required, okay? Or therapy only, plan of care, SN locator, SN skilled nurse to perform comprehensive patient assessment, to complete Oasis data per agency policy procedure, and identified immediate care needs on the same day as the therapist or within 5 days of the therapist visit. If it's a therapy only case, therapy can go in first, and they should get the contract signed, the client agreement. But they can go in and do their eval first. This is if it's a therapy only case. And then the nurse has 5 days to get in there to do the actual start of care. But you're going to indicate that it's a therapy only case. If it's a skilled nursing eval and you go in there and you decide this patient is not homebound, you do the assessment and the patient's like, oh, I don't have time for you tomorrow, I'm going to the mall to go shopping. This patient's not homebound and it would be a non-admit. And you would call me right away. But if it's nursing going out and nursing's gonna be in there and physical therapy is gonna be in there and all that good stuff, this is the indicator you're gonna use. Skilled nurse developed plan of care with patients. There was no caregiver. Patient involvement to be countersigned by physician. SN to perform complete physical assessment with each visit with emphasis on, and we know this patient we're going to do wound care and diabetic teaching, right? SN to assess other comorbidities including hypertension. Because she has a history of hypertension, and other conditions that present themselves during the episode of care. SN to recognize and intervene to minimize complications. Notify physician immediately of any potential problems that impede completion of patient recovery and desired goals. Okay? So that's done. And then rehab potential is fair, always. And then discharge plan. Well, number one, patient does not have a caregiver. She lives by herself, so she'll be discharged to self when the wounds are healed, and if there's a caregiver identified that can handle her insulin administration, or if she is able to demonstrate necessary skills to manage her care. Okay? And then at the very bottom here, you have your frequencies. So say you did wound care today, which is the 6th, and it needs to be done every other day. So your next visit would be on Saturday. Saturday is the end of the week for Medicare week. The Medicare week runs from Sunday to Saturday. So you saw the patient today, which is Thursday. That counts on your frequency. The next day the patient's due is on Saturday, so it's going to be 2 week 1. You're seeing the patient twice, 2 times in week 1. Then next week, you want the patient seen 3 times for 1 week. Then the next week, you want it to go back to 2 times a week for 2 more weeks. That's how you rate frequencies. The effective date is the date of the start of care. The start of care counts in your frequencies. So your frequency is for Thursday and Saturday, then Monday, Wednesday, Friday, then probably Monday and Thursday, okay? And PT is just 1 week 1. They have to do their eval, and if they're going in tomorrow, great, we know that. If they're not going in until next week, then we know that. But don't worry about that so much. But they're 1 week 1, that's pulling them in there to do their eval. And then when all of that is done, you can hit save and check for errors. And if there's anything that you missed, there is specific emergency preparedness. So we'll hit OK. We'll go down to emergency preparedness. And we missed this too. Choose a risk assessment. If this patient just came out of a hospital or rehab, you hit this first one. If you're seeing a patient that was not hospitalized or in rehab, it would be the bottom one. But we saw a patient that was coming out of the hospital. So there are problems with medications, principal diagnosis, physical limitations, patient support, she needs more help, prior hospitalization. And this orange box appears that says high risk potential for hospitalization problem statement below. Okay, nice. So first we'll do emergency preparedness. We've already marked it, so that's done. And we need to go down to the bottom where it says high risk potential for hospitalization. So here's risk for hospitalization. She's had 2 or more falls in the past 12 months. Maybe multiple ER visits, currently on 5 or more medicines, currently exhausted. There may be other risk factors. And if they're not taking their medications correctly, you're going to mark that. If she's in the hospital, if emotional or mental problems, you'll mark that. The height and weight, they're on our sheet that we filled out. So the height is in inches. So she's 5'4", that's 64 inches, and the weight was 146. Okay, we get to the bottom. This is all done. So we check for errors again. If there's anything we missed, it'll show up. Nope, no errors, no questions. Patient's primary diagnosis is diabetes, and then based on that, this is our expected payment. There is a scrubber that you can run. The scrubber will tell you if there's any inconsistencies. So in one spot, I put dress upper body, able to dress upper body without assistance of clothing is provided to patient. And then in the functional abilities, I put supervision or touching assistance. That matches as far as I'm concerned, so I'm going to leave it alone. If there was something that said, here you put independent, here you put the patient was dependent, then you need to go back and fix that. But these are very close, so that's not anything we need to worry about. All right, so that gives you some suggestions. Once you're done with that, you go back to your Oasis, your time in, your time out. You're going to sign it with your signature. And then your signature timeout needs to be the same as your time that your visit ended. Okay? All right, and then dates there. So then I'm going to hit finish. Here's your start of care. Here's your plan of care that it generated. Now we can go look at the plan of care. We have we wanna make sure everything is answered, okay? So we have the patient's information, the doctor's information, the progress, the allergies, the mental cognitive status, nutritional requirements, functional limitations, activities permitted and restricted, safety, DME and supplies, advanced directives, there is no caregiver, psychosocial, this emergency stuff, just pops in there. Then we have our medications listed. This primary diagnosis looks blank, but if you go down here, it's right here. It's the type 2 diabetes. For some reason, that's the way it prints out. The patient's face-to-face date is here. That's a wrong date. That would have to be changed. And then we go in and we make sure we have everything. We don't have the aids. So the aid did not populate into this. So I would, because I didn't do on that last page, so let me go fix that. Hold on. So I can show you correctly.
And I do have a question for you. For the item weight, can this be reported by the patient, or do we need to have it?
No, it can be reported by the patient, yeah. I don't expect you to carry that stuff around, that's too much.
Okay,
Yeah.
thank you.
All right, so I'm just going into the start of care in QA, and I'm gonna fix that last thing so the aid shows up, so you see it. All right, so we set for the aid, we're gonna give the aid. Today is Thursday, so there's no way the aid will get in this week, so it will be as of 03/10/25, 2 week. We'll give her an aid for 6 weeks for bath aid. So this will start as of the 10th. Save and check for errors. That is fine. Exit. Let me just go and update the plan of care. When you close your Oasis, it generates the plan of care. If you need to make any changes on your plan of care, you need to make them in your Oasis. So what we would do is delete your plan of care and send you back your Oasis, and you can add your corrections there. And then when you sign it and close it again, you would get a brand new plan of care with everything you need in it. Okay, so now, let me just make sure they're on here. Yeah, she's there. Okay, so let's go back. Okay, here's your, let's hit refresh all the time. Here you go. So your plan of care is way down here. So we covered the top part here. You have your medications and your oxygen, okay? Your diagnosis, your parameters, your nursing frequencies, PT, and the home health aid frequency, skilled nursing and the nursing interventions, the home health aid interventions, physical therapies intervention, the wound care orders. Here's the goals for nursing. PT will put their own goals in there. This is your rehab potential and discharge plan. If there's a caregiver identified that can be instructed and demonstrate competence with insulin administration, then we can go out. Otherwise, we're stuck in there giving the insulin. There's the homebound narrative, the medical necessity, your start of care narrative, and that's it. So you would be okay. You've done everything, and I'll do the HHA plan of care. And any questions on the start of care?
I have a question.
Sure.
So in terms of the frequency for when to go out, is this the doctor's order to say, oh, are the patients are supposed to have their home health for this specified, amount of days in a week, and for how many weeks?
Yeah.
Because I see you are putting, okay, twice in 1 week. So is it nurse and driven, or this is according to the doctor's order?
It's nursing driven. The only time that we see a doctor put frequencies is usually the orthopedic doctors. They might say they want their patient to have physical therapy 3 times a week for 4 weeks. So there we might do what the doctor says, but otherwise it's nursing driven. The nurse determines how many times the patient needs to be seen. And it's very common in home health that you're the one who's gonna come up with the wound care orders. You're gonna call the doctor and say, patient has a skin tear on her right hand. We don't call them skin tears in home health, we call them trauma wounds. So you're gonna say, the patient has a skin tear on her right hand, I wanna clean it with normal saline, apply OptiSite or Xeroform and foam dressing or whatever you're gonna do, however you like to treat skin tears, and then for how often, never daily. You know, skin tears really could be done 2 to 3 times a week. And we find that we do a lot of foam dressings. So if there's a flap, you steri-strip the flap, you might use skin prep around the edges and cover it with maybe Xeroform and then a foam dressing and leave it for 2 or 3 days before it gets changed. Technically, it could even go longer, it could go 3 to 4 days. But the doctors don't give orders usually on wound care, they'll say do whatever you want, send me an order, and that's what we do. But you call him, tell him there's a wound, ask if he wants any specific orders, they'll say yes or no, you make it up, and then we'll write the order.
Okay, so while you are on that, I just need you to try and, try and clarify for me. Because I work in the hospital, and when we have to discharge a patient with a wound, they normally ask for a consult with the specialist, a wound care specialist, and we send the patient home with the wound care orders. But you are saying that you guys make up and the wound care orders?
No, if the patient is discharged with wound care orders, then we follow those orders. But if you find a wound on a patient and you call the doctor and he's like, so. But a lot of times we have wounds, they come out of the facility with a wound, and the wound care orders that they send them with, we do, but then we'll call in a wound specialist to go in and they'll change the orders anyway, so.
All right, thank you.
Yep. So that's the start of care, which generates the plan of care. We wrote an order while we were in there, okay, and that order was for those medications that didn't have orders. So now that'll go to the doctor. And tomorrow, well, today, we'll say today, later, we'll say the LPN's going in there later. So now, when she goes in to open her note, hold on 1 second. Change this. So tomorrow, when the LPN goes in to see the patient, save. She'll go in, and the wound, it's not going to show us because it's the next day. Hold on 1 second, let me change that date back. Close. Okay, this is 6. Okay, so the LPN goes in to do the wound, and the wound is in her note now. So she has something to document on. If you hadn't put it in, she wouldn't be able to see the wound. Now, if she goes in before you put it in, you will no longer be able to put it in on your start of care. That's why the most important thing you can do is if there's a wound, if you don't have time to do the Oasis, no problem. But go in and put your wound in so that it shows up on the next visit. Okay? And if you are having trouble putting in your wound, call me and we'll put it in together just so it gets in there. Because there's nothing worse than having the LPN call and say, I'm here to do wound care and I don't see a wound on my note. And that's because it wasn't put in. Okay? Then, because you're RNs, you may have to do an LPN or an HHA supervisory visit. LPN supervisories are every 30 days, and HHA supervisories are every 14 days. They're really easy. It's one page. You just open it up, use your drop down to pick out the LPN that goes out there, and then you're putting whether the LPN was present or not. Most of the time not. If you're going out to do a supervisory visit, then you take the visit for the day, and the LPN doesn't go out. So it's usually no. And then, does the LPN maintain open communication process with the patient representative or any caregivers or family members? Does the LPN call you and let you know when there's going to be problems? Yes. You ask the patient, does she arrive at the time she tells the patient? Yes. Does she follow the plan of care? Yes. Does she demonstrate competency with the assigned task? Yes. Is she performing the correct wound care that you put on your plan of care? Does she inform you when there's a change in the patient condition? Does she comply with infection control policies and procedures? Does she honor the patient's rights? Now, you may be saying, well, I'm not there, so I don't know, but you're going to talk to the patient and ask the patient if she's doing these things. And at least one time a year, you have to do a visit with the LPN and the HHA, at least once a year. It says annual on-site supervisory visit. So if you're there with the LPN or the aide, you'll mark the date, okay? Then down here it says, were there changes made to the plan of care? If you didn't change anything, it's no. Is there any deficiency in nursing services identified with need for competency evaluation required? It's always no. If there's a problem, the patient reports to you that there's a problem, you call me and I deal with the LPN or the aide, but we don't want it documented that there's a problem, because then you have to do a whole plan of correction, and that is a lot of work. So if the patient does not like the nurse or the aide, or they did something that upset them, call me and then I will get involved and I'll do an incident report, but I don't want it on here, okay? Is the patient receiving insulin administration? If you're not going in to give the patient insulin, the patient is not receiving insulin administration. If you're not doing the wound care, the patient is not receiving wound care. But if you're going in to do the wound care, the patient is receiving wound care services, yes. And is the patient at a high risk for hospital readmission, yes or no? If you want to write anything additional down here, patient loves the nurse, patient loves the aide, or whatever, that's fine. Then you sign it, date it, your time, and you hit complete. The HHA and the home health aid care plan the supervisory visit look exactly alike. So it's just you picking out who you're doing the supervisory visit on. Okay, any questions? Okay. And then when you're in your visit notes, if it's an end of frequency note, before you leave the patient's house, you need to call us and say, today was the end of frequency, I think she needs to continue, her wound's not healed, and you tell us what you want, twice a week, whatever, and I'll write the order, or you'll write the order, and we'll send it to the doctor, and then we'll go ahead and continue frequencies, so you can keep seeing the patient. If you're in seeing the patient, where's my visits? And you find a new wound. Okay, so you're in there for this wound, and you find a new wound. You can go in here, and you can go to physician order, and it puts the date and the time, and you can put wound care. Okay. Go to wound care orders and add a new wound order. So say you found SN to perform wound care to right hand trauma wound. And then again, we're going to measure. cleanse with normal saline, blah, blah, blah. You know, you write the whole thing out. Okay, then you save it. It's here, you sign, signature time, what is it, 213? Create. Now, it's saying your physician order was entered and must be associated to a wound in the wound orders profile. Completing wound documentation without associating all orders will impact your organization's compliance. All right, so we said it's on the patient's right hand, so I'm gonna go to the back of the hand. I'm gonna put it right here, add. New wounds cannot be added on a late note when a current visit has already been started. I went and opened something. Let me see what I opened. Cancel. Save and exit. Okay, we have these are open. Let me get rid of these. Save. Okay. Anything else? That's not open. Okay. Alright, okay. So you can go in here, okay. We're gonna add new location. I don't know, it's not letting me, the narrative section of the clinical note can be used to document a late visit addendum. Okay. If you can't get your wound added here because somebody else opened a visit after your visit and you need to add something, you can add it in here in your narrative. New right hand trauma wound identified. And then I would put the measurements. SN to perform wound care twice a week. SN to cleanse wound with Okay, so if you can't get your wound added in under Integumentary, add it the same way you would down here, and let me know about it. Then I can pull it out of here and put it in for your next visit. Okay? Just remember, you want to measure. You want to measure and put a frequency so that we can send it out as an order. Okay, any questions?
Not yet.
Okay. So that is the basics of Axxess. If you are in with a patient, say this visit, and, the patient tells you that they are having burning when they urinate, so you suspect a new infection, you do an infection control surveillance report in the note. You start it here, suspected infection, UTI. You notify the physician always. If you told me, and then you go to the infection log, and it pre-populates the basics, and then you say physician notified, yes, always. And was this acquired after 72 hours of admission to home health, or was this associated infection within 24 or 48 hours of admission to home health? Infected prior to admission, okay, depending on what the patient tells you. And then, were their labs completed? You can put in here UACNS obtained. If the doctor ordered it, obtained. And, then you call me and we'll have William pick it up the next day. If the doctor orders an antibiotic right away, you can put it here. If he hasn't, just put no. If he gave you a new order, you can add a new med order here. If he gave you amoxicillin or whatever, you can add it here. And type of infection suspected, you're saying urinary. It'll ask you for signs and symptoms. If it's a wound, same thing, you'll get a drop down. Then you're going to say universal precautions. You can put a little brief thing here, SM reported, signs and symptoms, and you can name what they are. Notified Dr. Bradford, ordered to collect UACNS, office notified, lab will pick up tomorrow morning, urine sample placed in refrigerator. And then, once you tell me about this infection report, I'll go in, and once you finish that part, I'll move it like 5 or 7 days to the future, and you can do the follow-up. The follow-up documentation would be patient completed antibiotics, no further signs or symptoms of UTI, no further orders, and then you sign date and time, okay?
Okay.
Let's see, where else are we? Save. Coordination of care, like I said, everyone that's on the case you should be talking to. So if PT is in there, when you do a visit, you should indicate that you spoke to the physical therapist, put their name, patient report given, or reported to physical therapist that you instructed the med techs to make sure the Voltaren gets put on the patient's knees before physical therapy, something, whatever you talked about. It shows that we're all talking to each other. Never under discharge planning do you put NA. It shouldn't even be here. We start discharge planning from the very first visit. So it's always discharge planning discussed with the patient, a caregiver, the legal rep, or the doctor. Whoever you talk to, that's who you discuss discharge planning with. Another way to add an order is here. It says new or changed orders to POC required. Yes. New or changed order, you notify the patient that there's a change in their plan of care and you're going to add new orders. So we can say, say gastrointestinal. They're complaining of constipation. Plan of care. So we go here and we want to SN add order. You're going to select the problem statement in gastrointestinal status. Add. This is adding it to your plan of care, alteration in gastrointestinal status. SN to assess gastrointestinal status, identify any signs or symptoms of impaired gastrointestinal function, report significant changes to physician. SN to instruct patient on, and we're gonna say it's constipation, okay? Including who to contact if signs and symptoms persist or worsening, as well as dietary, hydration measures, and medication management were indicated. And then you're going to hit intervention to teach constipation, and you'll change it to individualize it for your patient. SN instructed patient to drink 3 bottles of water a day, to walk around the halls, I don't know, twice a day, something, whatever you taught. And then your goal is to have optimal bowel evacuation, return to stable gastrointestinal status, whatever you want to put here. Just make it individualized for your patient, and you're going to make sure it's dated. 2 weeks, 2 visits, 1 week, whatever. Okay? And then, actually, let me show you how that shows up in the plan of care. So, this. Constipation. Oops, almost in there. Get rid of these asterisks. You do not need to add medical necessity and homebound unless you want to. We're going to save and exit. Do we lose internet again?
I don't know. Is it not working? We lost it again?
I don't know. It's not doing anything. It's not telling me I missed anything. It's just not doing anything. Save. Save. Save and exit. Come on. Let's go. Well, it says I have plenty. Oh, it says not connected. Wait a minute. Great. Let me see that again. Not connected. Anyway, when you do that, it did not put it on here yet, but it would show up on here if I didn't lose internet. So, try again. Yeah, I don't have internet. Okay, so I can't show you there. Cancel. But that's how you do that. You can add an order this way too. You go into your meds this way, medication profile review. You can add. If you're not adding, you're just reviewing. And then you're going to sign that you reviewed your med profile with the date. If you can't remember if you signed, you can always look here and it shows you if you've signed it. I've done it twice so far. Okay? Then you come to where it says plan of care. Note that this intervention box is empty, okay? When you go into your plan of care profile, and, okay, patient is at high risk for infection, So one of the things you taught on today was signs and symptoms of UTI. So you're going to document. This intervention has been added to your note. Okay, remember I showed you the blank box. And then also at this visit you taught on pain. So you're going to hit document. And then you did the wound care too. SM performed wound care. You're going to hit document. Okay, that's all I did today. So now I'm going to hit save and exit. And to see in your intervention box, everything that you marked in your plan of care showed up here. So you don't have to write it. But you need to make it make sense. So you should put SN assessed for signs and symptoms of UTI. And you can put discussed signs such as burning with urination frequency, blah, 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 and with patient. Instructed patient regarding care of, regarding appropriate perineal hygiene, or appropriate perineal hygiene, dietary and fluid needs. SN instructed patient regarding strategies to mitigate pain. Include, just clean it up so that it makes sense that, yes, this is what you did. SN performed. Pressure ulcer care. SN cleansed wound with normal saline patches. Applied skin prep to peri wound. And covered with foam dressing. So remember, interventions are the things you did, so therefore it needs to read like you did them, not that you're going to do them or that somebody else is going to, that they were done. And then response, again, you can go right down the line here and you assess for signs and symptoms of UTI. No signs and symptoms noted. Patient is able to verbalize 3 out of the 5 signs that we discussed. Patient demonstrated appropriate perineal hygiene or verbalized the need to wipe from front to back. SN instructed patient regarding strategies to mitigate pain. I would say patient verbalized taking Tylenol when she has back pain, reports good results. Pain went from 5 out of 10 down to a 2 out of 10. And then, the wound. Patient experienced very little discomfort during wound care. Wound looks good, no signs of infection. Wound is 50% healed, 25% healed, whatever. Those are your response or progress towards goals. And then you'll put a little narrative. You have this new wound in there. We're going to pretend that didn't happen. Okay, and then there are templates here, but if you're going to use them, I'm going to warn you, they suck. So you have to really clean them up. So there is one in here for a visit. There's a start of care one, it's huge, you don't want it. There's a regular visit one, you can use it, but you're going to clean it up. So never put SN perform full body assessment, nobody cares. They want to know what you actually did. Okay, so you have that first sentence, and then you can put SN performed wound care, instructed, patients to always use walker. You know what patients do, they pick up the walker, they walk backwards, all those things. You might have caught her doing that, so you instructed her not to do that, or whatever your, narrative, whatever you did, you can put it in there, then you sign date and time, so. Today's date. Time. Complete. And it's telling me I have some errors, so I have to go back and see what I didn't fill out, which is a lot. So, okay, let me just go through here quick. Time in, let's say 1:30. Okay, let's make up some numbers here. You know, Michelle, it has not escaped my attention that it's freezing in here.
You lowered that AC, didn't you? Sorry.
Okay, save those. That's probably yesterday. Normal school, constipated. Okay. Oops, I marked there. Okay, and then we have to document on the wound, or it won't let us close. So we'll say, we didn't measure today. You only have to measure and take pictures once a week. If you want to do it every time you go, that's fine, but it's only required once a week. Once you're done, you can hit complete. It's saying there was another order entered. Now all of a sudden I must have internet, but we're not going to do it now, so I'm going to say not now. All right, so that closed the wound manager. And there's a wound. Okay. And we didn't do any labs. Nutrition, we'll put poor hydration. And diabetes, form. Again, if you don't have the values, just put the normal 70 to, it's usually 110 I think, but I'm going to put 70 to 2. Diabetic foot care, she's walking around without shoes on. We discuss the plan of care of the patient, ambulatory with a device. She has a walker, no carrier. Let's see, review the meds. Signature date.